Bisa tolong ditayangkan itu acara Neuro ICU di Banjarmasin. Saya kirimkan tadi ininya flyernya.
Ya, ya Prof. Nanti kita anukan diselang-seling bisa Prof. Diselang-seling sesi Prof. Halo, yuk kita mulai ya. Yuk, yuk.
Izin, Dokter Sudadi, berkenan dimulai sekarang, Dokter. Suaranya terdengar, Mbak gitu?
Ya, udah.
Siap. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Good morning for all colleagues and all audience. Department of Anesthesiology and Intensive Therapy, Faculty of Medicine, Public Health and Nursing, Gajah Mada University, Dr. Sarjito Hospital, Yogyakarta, Indonesia. Now proudly present of the 15th National Congress of Indonesia Society Neuroanesthesia and Critical Care, 7th Joint Symposium of Neuroanesthesia and Critical Care Indonesian Singapore, and 6th Biennial Symposium of Anesthesia Complication virtually on 22 July until 5 August 2021. And this event existing a scientific program with a lineup international and also local speakers who will bring us insight on the latest issue in neuroanesthesia, anesthesiology in general, emergency, and also critical care. In this event, we will give the opportunity for the participant to discuss, share, and engage in stimulating discussion at the various scientific session and presentation. Let me introduce first. My name is Haning Tirta Kusumawardani, and I'm as a Master of Ceremonial in the entire series of the symposium today. Before we start this symposium, allow me to read the attendance technical instruction of the symposium participant. The first, the attendance ID in this webinar must real name, not device name on institutional name. Attendants are strongly encouraged to mute during the webinar. All attendants who take part in webinar can ask a question by the writing their names, institutional or origin, and question briefly. All attendants have to fill the registration, just one for all the symposium that will be held during the event. And all attendants who do not fill the registration link will not get a certificate. And today we have 4 sessions. The first, plenary lecture and also opening ceremony. The symposium 1 with the topics of eras in neuroanesthesia. The symposium 2 with the topics traumatic brain injury. And the symposium 3 with topics brain tumor. And now, let we start the first session. For the opening, begin with the 2 remarks from the Prof. Ova Emilia and Dr. Sudadi. Prof. Ova Emilia.
Yang ini, buka ini.
Sorry. Prof. Ova Emilia.
Iya.
As a Dean of the Faculty of Medicine, Public Health and Nursing, Gajah Mada University. Thank you, Prof. Ova Emilia and Dr. Sudadi for the coming. Prof. Ova Emilia, Master of Medical Education, Obstetric and Gynecologic Specialist, Consultant, PhD, as a Dean of Faculty of Medicine, Public Health and Nursing, Gajah Mada University. Please Prof. Ova to giving some welcome speech and opening a series of symposium event today. Time is yours, Prof. Ova.
Thank you very much. Assalamualaikum warahmatullahi wabarakatuh. Apakah suara saya bisa didengar dengan jelas ya? Salam sejahtera untuk kita semuanya. Yang terhormat para narasumber yang telah hadir pada pertemuan kongres dan juga simposium, and also our speakers from neighborhood country. Kemudian juga yang terhormat Ketua Panitia Organizing Committee, Dr. Sudadi, dan juga seluruh partisipan yang telah mengikuti acaranya kelihatannya sangat padat ya, 3 acara sekaligus ya. Jadi ada kongres, ada simposium dan juga Biennial ya, Biennial. Baik, Ibu dan Bapak yang saya hormati, tentunya pertama kali kita panjatkan puji dan syukur kehadirat Allah Subhanahu wa taala yang telah memberi kita kesempatan hingga hari ini untuk tentunya kita bisa berkumpul dan kemudian juga berbagi ilmu, berdiskusi untuk tentunya sebuah kemaslahatan ya, misi yang diemban oleh profesi kita sebagai dokter. Ibu dan Bapak yang saya hormati, kami sangat berbangga bahwa dalam era pandemi ini kita juga masih sangat semangat untuk mengupdate keilmuan kita, karena begitu sibuknya kita dihadapkan pada berbagai masalah, berbagai tantangan di lapangan, dan sekaligus tentunya ternyata ya seperti yang kami alami sendiri di institusi kami, ternyata juga keilmuan juga bergerak dengan cepat, sehingga kita menyebutnya bahwa kita harus tetap updating dengan bukti-bukti terkini ya, living evidence. Dan kami juga sangat berbahagia dan mengapresiasi topik yang diambil juga sangat beragam, dan kelihatannya neuroanesthesia menjadi satu topik yang sangat cepat sekali berkembang, yang dibutuhkan bukan hanya untuk intervensi tetapi juga untuk diagnostik dan juga monitoring. Dan kami saya sendiri sebagai ahli kebidanan ya, obstetri dan ginekologi sangat erat bekerja dalam tim dengan teman-teman anestesiologi ya, yang tentunya tim anestesi ini luar biasa, adalah tim yang bukan hanya bekerja di dalam intervensi tetapi juga di dalam upaya diagnostik dan tentunya yang utama juga dalam kaitannya dengan rawatan intensif. Ibu dan Bapak yang saya hormati, saya tidak akan berpanjang lebar karena memang bidang anestesi bukan bidang yang saya pahami secara mendalam, tapi yang jelas saya mengucapkan apresiasi yang setinggi-tingginya kepada seluruh narasumber yang telah bersedia bersodakoh ilmu ya, sehingga menjadikan apa yang diberikan adalah amal jariah untuk Ibu dan Bapak semuanya. Also, my expression of gratitude to all the speakers that already share their knowledge in this event. Dan terakhir, kepada panitia, saya mengucapkan selamat dan penghargaan setinggi-tingginya untuk dedikasinya dan seluruh upayanya mewujudkan acara yang sangat padat ini jadi 3 acara sekaligus dan berjalan dengan lancar insya Allah. Billahi taufik wal hidayah. Wassalamualaikum warahmatullahi wabarakatuh. Selamat berkongres.
Thank Thank you, Prof. Ova, for the welcoming speech. And now we will continue the next speech from Dr. Sudadi, anesthesiology specialist, neuroanesthesia and regional anesthesia consultant, as a chairman of 15 INA-SNACC and 7 NACC Indonesian, Singapore, and 6 SOAC. Please, Dr. Sudadi, time is yours.
Assalamualaikum warahmatullahi wabarakatuh. Salam sejahtera untuk kita semua. Yang saya hormati Prof. Ova selaku Dekan FKKMK UGM, yang saya hormati Prof. Tatang Bisri selaku pembina dari INA-SNACC, Honorable Prof. Kiat from Singapore. Good morning to dear all honorable speakers and participants of the 15 INA-SNACC and 7 Joint Symposium Indonesian Singapore in conjunction with 6 Symposium on Anesthesia Complication SOAC. Alhamdulillah, countless thanks to Allah Subhanahu wa Ta'ala who has allowed us to meet again in the Biennial INA-SNACC, which was postponed in 2020 due to the COVID-19 pandemic. The COVID-19 pandemic that shocked our normal order of life in 2020 made us adapt to the new normal. In this new normal era, face-to-face meeting are gradually being replaced by virtual meetings, and greeting must be delivered online. However, I hope that this does not reduce the essence of this meeting itself. This is actually an effort to establish a relationship between us. For a moment, I would like to all of us pray for our colleagues and families who are currently unable to attend this event among us because of illness. May they be given complete healthy and healing soon. Ibu Dekan yang saya hormati dan seluruh pembicara dan peserta simposium, dapat kami laporkan bahwa Kongres ke-15 INA-SNACC tahun ini yang dibersamakan dengan Joint Symposium Indonesia Singapura dalam bidang neuroanestesi dan critical care, dan juga dibersamakan dengan SOAC yang ke-6. Ini merupakan serangkaian acara yang seluruhnya diselenggarakan secara online mulai dari tanggal 22 Juli tahun 2021 kemarin dan akan berakhir nanti pada tanggal 5 Agustus tahun 2021, hampir 2 minggu. Rangkaian acara ini terdiri dari 7 sesi simposium INA-SNACC, 7 sesi simposium SOAC, kemudian 6 industrial simposium, 9 group paper presentation. Jadi kita memfasilitasi dari peserta didik untuk melakukan presentasi nasional, apakah ini internasional ya, karena memang ada kewajiban dari peserta didik untuk mempresentasikan karya ilmiahnya di event nasional. Dan juga pada event ini ada 2 CPD untuk dokter spesialis dan juga untuk dokter konsultan neuroanestesi. Pada kesempatan ini saya mengucapkan terima kasih kepada seluruh pembicara yang terdiri dari 52 pembicara dari Indonesia, kemudian 5 pembicara dari Singapura, 2 pembicara dari Malaysia, kemudian dari Thailand, Filipina, dan India. Dan sampai hari ini tercatat lebih dari 1.000 peserta yang sudah mendaftar dan insya Allah akan berpartisipasi dalam rangkaian acara ini. We would like to thank to all of the speakers from all over Indonesia, also from Singapore, Malaysia, Philippines, India, and Thailand, who have spared the time to share knowledge in this event. Even though we are physically separated by distance and time, I hope this event can be the best of use for the advancement of neuroanesthesia in Indonesia. Demikian sambutan dari saya, kurang lebihnya mohon maaf. Bila wal hidayah. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. We also having moderators and speakers from the international speakers. Good morning for the Professor Kwek Tong Kiat from Tan Hock Seng Hospital, Singapore. Hello, Prof. Can you hear my voice? Prof. Kwek Tong Kiat. And also we have some moderators from all institutions in Indonesia. And now we will starting the plenary lecture. Welcome to the speakers and moderators, the Honorable Dr. Sri Raharjo, Sp.An, KNA, NCC, KAO, FIPM, from the Sarjito Hospital, Yogyakarta, Indonesia as moderator. The first speaker, Dr. Bambang Suryono, Soewondo, Sp.An, KIC, KNA, M.Kes, from Sarjito Hospital, Yogyakarta, Indonesia, with the topics of patient safety and ERAS, enhanced recovery after surgery. And the second speaker, Prof. Dr. Tatang Bisri, Sp.An, KNA, KAO, from the Santosa Hospital and Melinda Hospital, Bandung, Indonesia, with the topic, What's New in Neuroanesthesia in Traumatic Brain Injury. And third speaker, Prof. Kwek Tong Kiat from Tan Hock Seng Hospital, Singapore, with the topics Neurologic Manifestation of COVID-19. And the fourth speaker, Prof. Jian from Tan Hock Seng Hospital, Singapore, with the topics cardiac output and cerebral blood flow connection. And let me telling for the curriculum vitae of Dr. Sri Raharjo, Sp.An, KNA, NCC, KAO, FIPM. 1984, Dr. Sri Raharjo graduated from the Medical Faculty, Surakarta University. 1999, Dr. Sri Raharjo graduated from the Anesthesiology Specialist, University of Gajah Mada. And 2005, graduated from PhD from Pajajaran University. To 2005, graduated from the Neuroanesthesia Consultant, Pajajaran University, and also graduated from the Obstetric Anesthesia and Fellow International Pain Management. Let me the Dr. Sri Raharjo, Specialist Anesthesi, Konsultan Neuroanestesi, Konsultan Obstetric Anestesi FIPM, as a moderator to take over the guidance of the material session and discussion of this symposium. The time is yours, Dr. Sri Raharjo.
Okay, thank you. Good morning, ladies and gentlemen, and welcome in 15th National Congress of Neuroanesthesia and 7th Joint Symposium of Neuroanesthesia and Critical Care in Indonesia, Singapore. And now, although all speakers was able to join in Zoom meeting, although in the pandemic crisis due to COVID-19 outbreak, and we hopefully soon returns to the normal situation. Thank you to all speakers, and thank you to all committee of the meeting, and thank you to all participants and audience to present in the plenary lecture. In the plenary lecture, we have a 4 topics. The first topic, patient safety and early recovery after surgery by Dr. Bambang Suryono from Sarjito General Hospital, Indonesia. And then the second topic, what news in neuroanesthesia in traumatic brain injury by Professor Tatang Bisri from Hasan Sadikin Hospital, Bandung, Indonesia. And the third topic, neurologic manifestation of COVID-19 by Professor Kwek, Tong, Kiat from Tan Tock Seng Hospital, Singapore. And then the final topic, cardiac output and cerebral blood flow connection by Professor Jian from Tan Tock Seng Hospital. And please to the first speaker, Dr. Bambang Suryono, and 20 minutes for your presentation. Thank you very much.
Selamat pagi, Assalamualaikum warahmatullahi wabarakatuh. Good morning, everybody. This morning I have a chance to present this patient safety and enhanced recovery after surgery. Jadi topik ini mungkin tidak berhubungan langsung dengan neuroanesthesia dan neurocritical care, karena memang ketentuan ID bahwa setiap pertemuan ilmiah harus menyertakan topik etiko-mediko-legal. Jadi saya kira kita sudah tahu tentang apa enhanced recovery after surgery atau ERAS ya, atau yang juga ERP, Enhanced Recovery Pathways. Jadi ini adalah suatu pelayanan yang multimodal, ya, komprehensif, ya, meliputi beberapa departemen sekaligus ya, bedah, anestesiologi, mungkin perawatan, dan tetap memakai kaidah-kaidah apa yang berdasarkan evidence, ya, kaidah-kaidah praktek yang berdasarkan evidence. Jadi ini sebetulnya ada pergeseran dari perawatan yang selama ini ada sendiri-sendiri departemen menjadi dikoordinasi, menjadi model yang multidisiplin, mengintegrasikan semua komponen-komponen yang ikut di dalam tindakan pembedahan, yang berbedah perawatan dan anestesiologi pada suatu pekerjaan atau alur yang hampir tidak ada batasnya gitu ya. Jadi inilah apa yang disebutkan ERAS. Itu adalah sebetulnya tujuannya itu keinginan untuk memperbaiki kualitas. Jadi pelayanan dari pembedahan tidak jadi tidak memakai pengetahuan baru, tapi mengintegrasikan apa yang kita sudah tahu. Dan ini diinisiasi sudah agak lama, tahun 1990 itu sudah dimulai. Nah, di Indonesia baru dikenalkan beberapa tahun yang lalu oleh teman kita, Dr. Susilo Chandra, dan teman-teman semua mungkin beberapa sudah mengikuti workshop tentang ini. Inilah yang namanya ERAS ya, bagaimana ERAS itu bekerja. Kita ada namanya functional status ya, status fungsional. Jadi pada pre-op ya, katakanlah ada ini garis datar functional status ya di sini. Nah, kemudian pada operatif, karena dia di anestesi, di sedasi, di bius dan sebagainya, fungsional status kan pasiennya dalam keadaan tidak sadar. Pada operasi, pos operasi dia mulai dibangunkan, recovery, ya, nanti kembali pada status awal. Nah, ini diharapkan bahwa ini berlangsung lebih cepat ya dibanding situasi yang biasa. Nah, kemudian juga ada upaya namanya prehabilitasi. Keadaan pasien sebelum operasi itu diperbaiki lebih dahulu dengan nutrisi dan sebagainya. Nah, sehingga kondisinya lebih bagus daripada pre-existing tadi. Nah, kemudian selama operasi ya tadi seperti itu, tapi tidak sampai mencapai yang paling titik terendah di sini. lalu dia pun kembali pun lebih cepat. Ya. Jadi kalau ini ada garis hijau, ini garis merah, garis merahnya lebih panjang. Ya. Jadi
dokter,
dia
slide-nya belum tampil, dokter. Slide-nya belum tampil.
Oh, maaf. Belum share screen ya? Nah, nih. Sebentar. Aduh, belum share screen. Share screen, tolong.
Ini kenapa?
Share screen. Lupa tadi di bawah. Iya, share screen. Maaf ya. Nih. Mana?
Kenapa?
Belum. Sini.
Bisa nggak? Udah. Yang mana? Ini.
Iya.
Udah ke-share belum?
Udah kelihatan? Sudah di?
Sampun, dokter, sampun. Tinggal
ya?
slideshow mawon, slideshow.
Oh, slideshow ya.
Yang slide keberapa? Apa masuk di sini?
Di bawah aja ada gambar slideshow. Di bawah mawon. Di bawah.
Oh iya, ya situ.
Ya.
Di slideshow.
Sampingnya 70% nih, dok.
Gigi.
Di bawah, sampingnya. Ya.
Ya, maaf ya. Jadi ini tadi ya diawali lagi ya. Patient safety ini ada yang tadi kompetensi.
Dok, lanjut aja pada
ya. Ini ya gambar ini ya.
Ya,
jadi ini ada pre-existing functional status. Ya, jadi kita yang ini bisa lebih pendek jadi kalau dengan ada rehabilitation. Jadi yang namanya rehabilitasi itu adalah upaya untuk memperbaiki nutrisi, keadaan fisik, ya, kemudian sampai menghentikan rokok dan sebagainya. Ya, ini mengoptimalkan keadaan pasien sehingga nanti erasnya akan lebih pendek ya. Nah, kemudian di lain sisi kita mengetahui adanya yang namanya risiko, ya, risiko dari potensi terjadinya kerugian. Kalau risiko klinis itu semua isu yang berdampak terhadap pencapaian pelayanan pasien. Nah, kategori risiko di rumah sakit itu ada beberapa macam, itu ada patient care related, ada medical staff related, ada employee related, property related. Tapi tentunya karena kita di anestesi kita lebih bicarakan tentang patient care related risk ini. Nah, patient care related risk ini terutama yang paling penting adalah patient safety ini ya, meskipun nanti juga akan bicara juga tentang patient comfort, ada early discharge planning, ada low financial risk dan sebagainya. Nah, sedang patient safety sendiri sebetulnya baru 2004 inilah WHO mencanangkan gerakan patient safety. Nah, kemudian di Komite Keselamatan Pasien Rumah Sakit oleh Persi baru 1 Juni 2005. Kemudian ada gerakan keselamatan pasien oleh Menteri Kesehatan pada 21 Agustus 2005. Jadi belakangan. Ya. Nah, patient safety ini memang dicanangkan kalau yang di sebelah kanan ini safety adalah prinsip-prinsip yang mendasar pada perawatan pasien dan komponen yang kritikal pada manajemen quality. Ini menyangkut soal etik. Nah, kemudian juga ada hal yang penting nih quality, patient safety, risk management. Jadi di dalam kegiatan kita seperti ERAS, tetap kita harus memperhatikan quality, patient safety, dan risk management. Dan ini semua harus berdasar evidence based dan value based. Nah, seberapa besar sih problem patient safety ini? Ya, dari Catchpole 2008 itu pada 2 tahun period itu ternyata hampir lebih dari 12.000 anesthetic error. Ya. Tapi untungnya 70% diantaranya adalah no harm, jadi near miss ya, tidak terjadi kejadian. Nah, oleh karena itu mereka merekomendasikan bagaimana kita mengurangi kemungkinan terjadinya harm, kemudian bisa menemukan dan manage secara harm itu secara secepat-cepatnya, sehingga terjadilah never events kan, ya ini serius ya, bisa preventable, tapi ini tidak boleh terjadi. Nah, ini biasanya yang kita lakukan kita itu dengan checklist itu yang itu antara lain yang kita kerjakan. Nah, kemudian jadi kampanye besar-besaran Patient Safety 2007 ya, itu terutama mengurangi infeksi pembedahan, kemudian kita membuat peralatan untuk komunikasi dan terlibat dalam perioperatif. Tadi kita ada checklist, kalau teman-teman ada time out, sign in, sign out, ya itu adalah bentuk-bentuk komunikasi di dalam tim untuk mengurangi mortalitas dan morbiditas. Jadi apakah sebetulnya ERAS ini memenuhi syarat untuk patient safety ya, karena kita selama ini sudah banyak mengerjakan itu. Tapi ya analisis tadi ERAS itu tidak hanya bedah, tapi juga bedah, anestesi dan perawat. Nah, kita bicarakan bagian dari anestesi. Yang di atas itu adalah kita yang selama ini kita pelajari dengan workshop dan sebagainya itu adalah technical protokol aja sebetulnya. Nah, sebetulnya di samping itu ERAS itu harus memanage, yang sebelah kiri itu bagaimana kita ada pendidikan yang atau penyuluhan yang spesifik pada pasien sebelum operasi. Nah, kemudian juga dukungan institusi, departemen atau rumah sakit, bagaimana kita akan melakukan ERAS ini. Jadi ERAS itu tidak bisa dilakukan per departemental, tapi harus beberapa departemen sekaligus dan harus dikerjakan bersama-sama. Nah, ini yang rekomendasi dari ERAS WT. Jadi mereka ada evidence-nya ya, dari high sampai very low sampai high, kemudian ada rekomendasi yang kuat itu kalau panel itu merasa sangat yakin bahwa efek yang diinginkan itu bisa melebihi dari efek-efek yang tidak diinginkan. Kalau weak itu saya kira mereka kurang yakin ya, kalau bahwa efek yang diinginkan itu bisa melebihi dari yang tidak diinginkan. Nah, ini saya kira kita di anestesi ada periode preoperatif, intraoperatif dan postoperatif. Ya.
Waktu tinggal 10 menit, Dok.
Ya, ada pre-admission information ya. Jadi ini kebanyakan kita untuk ERAS ini operasinya elektif ya. Jadi kita ada waktu yang cukup untuk ketemu dengan pasien, education dan counseling ya, untuk mengurangi kecemasan, ketakutan dan sebagainya ya. Dan menjelaskan nanti Kwek hospital discharge. Jadi sekarang pun pasien itu bisa, ya kita ada kasus pagi jam 7 pagi minta URS, terus dok nanti jam 12 siang bisa enggak webinar. Nah, inilah ya kemajuan apa yang kita, jadi dia webinar dari rumah sakit, ya, habis operasi ya itu bisa aja terjadi. Jadi kemudian ini sangat strong ya rekomendasinya. Ya. Kemudian preoperative medical optimization ya. Ini kalau di barat itu tentang abuse penyalahgunaan alkohol, karena ini banyak komplikasi pada kardiopulmoneri dan sebagainya. Nah, ini mereka harus dihentikan 1 bulan sebelumnya. Nah, ini meskipun efisiensinya low to high tapi tetap rekomendasi strong. Nah, ini apa yang sering kita temukan pasien di klesma, diurus-urus itu ya. Ini malah sekarang should be avoided, jadi tidak usah dikerjakan dan tidak boleh dikerjakan. Ini kan bisa dehidrasi, bisa ya nanti malah keluar kotoran dari sana, ya, paranalisis. Ya, ini rekomendasinya strong ini ya, tapi ini untuk bedah lah saya kira ya. Nah, kemudian fasting. Jadi 2 jam sebelum operasi, sebelum anestesi ini masih boleh minum ya, clear and high carb liquid, air putih hangat manis ya, Kemudian solid food ini 6 jam sebelum surgery. Ini rekomendasinya juga strong. Ya. Nah, pre-anesthetic medication, long acting sedatif itu harus dihindari itu ya, karena ini bisa mengurangi mobilitas, cepatnya mobilitas dan kecepatan oral intake nanti. Jadi mereka merekomendasikan short acting anesthetic dengan ditambah regional anesthetic procedure ya. Jadi ini supaya lebih banyak dipakai yang itu. Nah, kemudian thromboembolism ya, DVT itu pada ini kolorektal ini hampir 30%. Nah, ini maka mereka menganukan mechanical thrombolysis to reduce DVT atau pakai low molecular weight heparin ya, untuk mengurangi DVT dan RT. Ini rekomendasinya strong. Antibiotik ya 30 sampai 60 menit sebelum insisi, dan kalau operasinya panjang ya, bisa diulangi. Ini juga evidence-nya high, rekomendasinya strong. Kemudian standar anestesi protokol ini yang trimodal approach ini, jadi mengurangi post-op penggunaan opiat, cepat bangun dan cepat enteral intake dan mobilisasi. Ini juga rekomendasinya strong. Jadi jangan dibiarkan dia terlalu lama berbaring ya, cepat-cepat dia dimobilisasi. Nah, ini oleh karena itu dianjurkan banyak memakai epidural analgesi ya, daripada dipakai OPW. Ini nausea vomiting ya. Jadi tujuannya utamanya adalah mengurangi opiat ya, karena ini banyak jadi komplain untuk bikin PONV. Jadi lebih baik NSS ya. Ini meskipun evidence-nya mungkin penelitiannya tidak banyak, tapi rekomendasinya high. Laparoskopi surgery kalau bisa itu jauh lebih bagus ya. Itu dibanding pada operasi-operasi. Kemudian nasogastrik. Nasogastrik itu sebenarnya tidak usah rutin ya. Kalau perlu dipasang intraoperatif aja. Kalau sesudah selesai reversal anestesi udah dicopot aja. Dan ini saya kira kita bisa bicara dengan dengan teman-teman KBD, beda digestis. Saya kira mereka setuju juga kalau habis kolesistektomi itu ya di RR sudah di OK sudah langsung dicabut, mereka setuju juga. Nah, kemudian kita harus menghindari hipotermi ya, karena hipotermi bisa memberikan ada masalah-masalah kardiak, ada bleeding dan infeksi. Nah, jadi ini mesti tetap normotermi, ini strong. Nah, kemudian perioperative fluid management ini jadi jangan sampai overload lah cairan itu ya, karena ini bisa bikin edema usus dan paru ya. Jadi pergeseran cairan harus diminimize ya. Jadi tadi seperti jangan usah diurus-urus, jangan usah diklisma ya. Juga jangan sampai hipovolemi karena perdarahan. Ini rekomendasinya strong. Nah, ini routine drainage, jadi drainase itu drain dari abdomen itu bila perlu banget lah dipasang ya, ini untuk bedah. Kemudian pasang kateter itu bisa 1-2 hari aja, tapi kalau bisa ya secepatnya lebih cepat lah copot ya, dan pasiennya bisa mobilisasi.
Tinggal 5 menit dok.
Ya, saya kira cukup ya. Kemudian post operatif rekomendasinya jadi laparoskopik itu lebih cepat ya, jangan sampai overload. Nah, ini ada yang mengunyah permen karet itu ya, katanya mereduksi ileus katanya ya. Ini strong rekomendasinya. Nah, ini untuk bidang kita optimal analgesi, jadi memberikan bagus nyeri, penanganan nyeri yang lebih baik, cepat mobilisasi dan fungsi usus cepat baik, bisa cepat makan ya. Jadi habis operasi itu saya kalau sudah nggak mual, nggak muntah, ya, minum aja air clear water paling enggak ya, secepatnya nanti ya bisa intake per oral. Kemudian ini saya kira analgesi juga pakai lodus epidural ya, short acting opiat ya. Kemudian ini karena ini sedikit hipotensi dan sedikit juga karena simpatik block ya. Ini strong. Kemudian early enteral feeding ini ya, ini sudah sangat terkenal. Tadi ini mengurangi infeksi, hospital long stay-nya turun, dan tidak ada disensi lah pada luka operasi di usus ya. Rekomendasinya strong juga. Ini dulu yang tahun 90-an, 80, 90 ya. Itu ada imunonutrisi. Ini ternyata sekarang tidak direkomendasikan lagi. Jadi kita tidak perlu memakai itu glutamin, arginin, omega 3 ya sebagai nutrisi di perioperatif. Kemudian gula darah, saya kira kita tahu semua kalau HbA1c-nya tinggi itu memang lebih banyak komplikasi. Kemudian kita harus kontrol hiperglikemi ya di bawah 200 ya, antara 100 ya kira-kira 120. Jadi ini sangat bagus. Kemudian mobilisasi yang lebih cepat ya, ini mengurangi komplikasi tes ya, paru-paru. Kemudian juga menghindari resistensi insulin. Kemudian mempercepat kekuatan otot kembali lagi. Audit, nah inilah yang sebetulnya sesuatu yang harus kita kerjakan. Jadi ERAS tidak bisa hanya ya kita melakukan sesuatu teknik anestesi terus kita sudah menganggap memakai ERAS. Jadi ERAS itu harus diorganisir multidisiplin, ada organisasinya ya. Kemudian dia ada periodic auditing, harus diaudit. Ya. Jadi supaya ini selalu program ERAS ini bisa memperbaiki kualitas di dalam pelayanan kesehatan. Ya. Jadi tidak bisa kita sudah mengklaim, sudah melakukan ERAS, tapi sebetulnya nggak ada organisasinya, nggak ada auditnya. Nah itu tidak boleh. Nah inilah jadi ERAS pada transition perioperative care ini terjadi early recovery dan discharge from hospital. Yang jelas itu tetap kita memakai evidence best practice dan sehingga mengurangi morbidity. Nah, kalau kurang morbidity ini kan patient safety ini kan, ya, jadi sudah jelas. Jadi ERAS pun sebetulnya tetap memperhatikan patient safety, juga mengurangi readmission, juga mengurangi cost. Ini efek yang lain daripada ERAS. Tapi karena konteksnya kita patient safety, jelas bahwa dengan turunnya morbidity, turunnya mortality, ini kan patient safety. Ya. Tentunya lebih lagi kalau kita bisa melihat mengontrol keluhan-keluhan yang lain. Ini saya kira Dr. Sri dan teman-teman sejawat sebagai kesimpulannya. Jadi early recovery after surgery itu adalah suatu multimodal multidisciplinary ya, ada organisasinya ini harusnya antara anestesiologi, bedah, perawatan. Kemudian harus berdasar evidence based practice, ada standardized care-nya, ya, ada standar nanti distandardisasi nanti premennya pakai apa, induksinya pakai apa, ya, analgesinya pakai apa itu ada standardisasinya. Ada beberapa contoh itu dari John Hopkins, ya, ada standardisasinya. Tidak hanya tergantung masing-masing orang, tidak bisa begitu, tidak depend on the people, tapi depend on the system. Kemudian ini adalah untuk elective procedure ya, belum nggak ada yang untuk emergency ya. Neuroanesthesia sendiri saya kira juga saya belum pernah baca yang banyak itu digestif, kolorektal, ortopedik ya. Dan kemudian ini sangat bagus untuk
waktu Dr. Bambang.
Ya, ini terakhir. Jadi saya kira ERAS ini adalah bisa mendukung memenuhi kriteria patient safety dan memberikan outcome yang lebih baik pada pasien. Terima kasih Dr. Sri dan terima kasih semua perhatian. Lebih kurangnya mohon dimaafkan. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Terima kasih kepada Dr. Bambang. Thank you very much to Dr. Bambang. And then we go to the second topic. What news in neuroanesthesia for traumatic brain injury by Professor Tatang Bisri from Santosa Hospital, Bandung, and from Hasan Sadikin Hospital, Bandung. Okay, and then 20 minutes to presentation for Professor Tatang. Thank you very much.
Terima kasih, saudara moderator. Yang Dr. Bambang di stop dulu ya slide-nya.
Sudah, dokter?
Oh, udah.
Ya.
Yang saya mana ya? Ya.
Sudah, Prof.
Sudah.
Prof.
Yes. Sebentar. Gimana stop? Bisa dibantu panitiain gimana ya?
Prof, tanda panah di bawah, Prof. Tanda panah di bawah, kiri bawah, ada kanan kiri.
Ini.
Ya. Kanan bawah, kiri bawah ada.
Ya,
ada.
Ini ada tulisan continue ya.
Ya.
Izin share-nya PowerPoint sudah kami share, Prof. Kami bantu saja, Prof.
Ya, silakan. Ya, udah ya. Dari awal. Ini kok jadi nomor 2 dulu? Ya, silakan dari panitia aja slide-nya. Ya. Terima kasih, saudara moderator. Selamat pagi para hadirin sekalian. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Good morning, my friends from Singapore, from Malaysia, Philippines, Thailand, and India. Nice to meet you again in this meeting. Topik yang akan saya sampaikan adalah tentang apa yang baru di dalam neuroanestesi untuk traumatic brain injury. Next slide, please. Kita semua sudah tahu, sudah membaca tentang adanya guideline edisi 4 yang dikeluarkan oleh Brain Trauma Foundation dari Amerika pada tahun 2016. Seluruh isinya adalah berkaitan dengan pekerjaan kita dalam mengelola pasien traumatic brain injury baik di OK ataupun di neuro ICU. Tapi setelah itu dari 2016 sampai dengan hari ini, apa yang terjadi yang bisa membantu untuk tindakan kita dalam pengelolaan pasien. Maka kita akan mengkaji apakah ada yang baru setelah Brain Trauma Foundation 2016. Karena di Brain Trauma Foundation 2016 tidak dibahas secara detail tentang teknik dan obat anestesinya. Slide. Ya. Kita tahu bahwa untuk penanganan anestesi, maka kita kenal konsep dasar dari neuroanestesi, yaitu yang disingkat sebagai ABCDE neuroanestesi, di mana kita mengatur airway, breathing, circulation, drug, dan environment. Slide. Pada 2016 sampai 2017, maka kita akan mencoba mengeksplor apa yang baru atau berubah dalam ABCD neuroanestesi ini, airway, breathing, circulation, drug, dan environment-nya. Jadi setelah saya lihat, maka akan saya tekankan saja, tidak usah semuanya, yaitu untuk airway breathing, bagaimana pengaturan PaCO2, untuk circulation, tentang autoregulasi cerebral, tekanan darah, dan tekanan intrakranial. Tentang obatnya, D adalah apakah kita memakai teknik anestesi TIVA atau pakai anestetika inhalasi. Sedangkan environment temperatur kontrol, saya kira hampir tidak berubah. Slide. Bagaimana tentang pengelolaan PaCO2? Yang kita tahu yang disampaikan di Brain Trauma Foundation Guideline 2016. Disebutkan bahwa cerebral blood flow itu menurun dalam 1 hari pertama pada cedera otak traumatik berat itu menurun hampir 50%. Jadi cerebral blood flow menurun 50% dan bisa pada makin ringan suatu cedera otak traumatika, maka penurunan cerebral blood flow pun makin kecil. Sehingga karena pada cedera kepala berat itu diperkirakan cerebral blood flow menurun 50%, maka hiperventilasi kontraindikasi pada atau untuk pasien cedera otak traumatika dalam 24 jam pertama. Apa yang baru sekarang? Kita lihat yang ditulis di Miller Anesthesia 2020. Hampir sama bahwa targetnya adalah normokarbi. PaCO2 diatur antara 35 sampai 40 mm Hg. Karena hiperkarbi akan meningkatkan cerebral blood flow dan mengganggu cerebral autoregulasi. Sedangkan hipokarbi akan memelihara autoregulasi kurve autoregulasi dengan penurunan cerebral blood flow. Tapi hiperventilasi yang berat akan menyebabkan PaCO2-nya menjadi menurun dan bisa terjadi cerebral ischemia. Slide. Nah, pada masa lalu dikatakan banyak buku yang menyebutkan bahwa autoregulasi itu antara MAP 50 sampai 150 mm Hg pada otak yang normal ya. Jadi cerebral blood flow tetap dipertahankan 100 gram per cerebral blood flow dipertahankan 50 sampai 54 cc per 100 gram jaringan per menit. Pada autoregulasi MAP 50 sampai 150. Di Miller Anesthesia disebutkan bahwa lower limit autoregulasi itu MAP-nya 70 mm Hg. Ini akan menyebabkan perubahan dalam pengaturan tekanan darah kalau kita mengelola pasien dengan cedera otak traumatika. Jadi batas bawah yang autoregulasinya bukan 50 tapi 70. Slide. Kita tahu juga bahwa apabila terjadi trauma pada kepala, maka ada yang disebut sebagai cedera otak primer dan cedera otak sekunder. Pada saat terjadi cedera otak primer, maka autoregulasi hilang. Blood-brain barrier juga hilang, terganggu. Pada saat cedera otak traumatik yang primer itu, maka bisa terjadi sistemik hipertensi sebagai tanda casing untuk peningkatan tekanan intrakranial. CPP, cerebral perfusion pressure, adalah MAP dikurangi ICP. Ini adalah kata kuncinya di mana kita harus mengatur MAP karena ICP akan naik supaya apa? Supaya cerebral perfusion pressure tidak terganggu. Pada saat cedera primer, cedera otak primer, juga terjadi pelepasan kateholamine yang banyak. Ada pelepasan sitokin. yang menyebabkan perubahan-perubahan pada jantung, dan pelepasan sitokin dapat menyebabkan kebocoran dari kapiler sehingga akhirnya terjadi pulmonary edema. Sehingga di sini jantung dan paru juga akan terganggu. Next slide. Kita lihat pada gambar ini menunjukkan bahwa pada kejadian trauma kepala itu, maka tadinya yang autoregulasi antara dari mulai yang batas bawah 70, gambaran yang normal, yang biru, kemudian akan menjadi hilang. Autoregulasinya akan hilang. Slide. Bagaimana konsep hipertensi pada cedera otak traumatika ini? Tadi telah disebutkan bahwa makin berat suatu trauma kepala, maka kateholamine plasma itu makin tinggi. Akhirnya perubahan pada efek pada jantung juga akan menjadi lebih berat. Kebocoran kapiler akan menyebabkan terjadinya pulmonary edema. Pengaturan tekanan darah akan menjadi sangat penting karena apabila tekanan darah lebih rendah di bawah batas bawah autoregulasi, karena autoregulasinya hilang, maka bisa terjadi cerebral ischemia, kemudian cerebral infarct. Tetapi apabila tekanan darahnya meningkat lebih daripada batas atas autoregulasi, maka bisa terjadi edema otak dan perdarahan otak. Jadi menjadi pertanyaan pada kita, bagaimana target tekanan darah pada traumatic brain injury? Berapa boleh naik? Berapa boleh turun? Ini yang disampaikan di Neurosurgical Focus 2019 setelah Brain Trauma Foundation Guideline 2016 keluar. Next slide. Jadi apa yang baru ini? Pada Brain Trauma Foundation Guideline 2007, yang disebut hipotensi itu bila tekanan darah sistolik kurang dari 90. Mana dulu kita ingat ya, pada kalau mengerjakan pasien, berdasarkan yang 2007, tekanan darah sistolik tidak boleh kurang dari 90. Pada tahun 2016, sekarang dirubah menjadi hipotensi itu bila tekanan darah sistolik kurang dari 110. Jadi pada perawatan baik pre-op selama anestesia atau post-op, maka kita harus menjaga supaya tekanan sistolik jangan kurang dari 110 mm/Hg. Bagaimana setelah itu, setelah 2016? Berubah atau tetap atau bagaimana? Next slide. Targetnya kita harus melihat cerebral perfusion pressure. Pada tahun 2007, cerebral target CPP adalah 50-60. 2016, 60-70. Ya. Kita tidak boleh lebih mengatur cerebral perfusion pressure lebih dari 70, sebab bisa terjadi edema paru. Ya. Kita bisa menghitung sekarang. Di monitornya bisa kita lihat berapa MAP yang diperlukan. Misalnya kita anggap 60 dan tekanan intrakranial 20 atau 25, maka MAP itu minimalnya 80 sampai 85. Bila 70, 90 sampai 95. Jadi kita akan mengatur MAP antara 80 sampai 90. Next slide. Rekomendasi tentang berapa ambang cerebral perfusion pressure. Nah, tadi telah disebutkan pada guideline 2016 bahwa cerebral perfusion pressure itu 60 dan sampai 70 mm/Hg. Karena bila terjadi cerebral perfusion pressure lebih dari 70 mm/Hg, apakah dengan pemberian cairan atau dengan pressure, maka ada terjadi risiko ARDS. Slide. Slide. Minta tolong slide-nya. Jadi kenapa sekarang rentang MAP itu demikian kecil ya? Tadi disebutkan rentangnya berapa. Karena kita tahu bahwa cerebral autoregulasi sudah hilang, blood-brain barrier sudah rusak, cerebral blood flow itu juga tergantung dari tekanan darah, hipotensi bisa menyebabkan hipoperfusi, hipertensi menyebabkan hiperperfusi, dan cerebral edema. Sehingga sangat penting dalam pengaturan tekanan darah ini. Slide. Nah, kita lihat pada Brain Trauma Foundation Guideline 2016 dikatakan bahwa pertahankan systolic blood pressure pada 100 mm Hg untuk pasien usia 50-69 tahun atau lebih 110 mm Hg atau lebih pada pasien 15-49 tahun atau lebih 70 tahun. Nah, karena dengan pengaturan tekanan darah sekian, maka dipertimbangkan mampu menurunkan mortalitas dan memperbaiki outcome. Bagaimana yang baru? Supaya gampang dikatakan saja bahwa hindari tekanan sistolik di bawah 110. Next slide. Bagaimana tentang monitoring ICP? ICP monitoring menjadi standar untuk dipasang pada pasien dengan cedera otak traumatika berat. Karena kita kalau mengelola pasien dengan informasi yang kita peroleh dari berapa tekanan intrakranial pasien tersebut, maka mampu menurunkan mortalitas. Tentang apa indikasi tentang pasien mana yang dipasang monitoring tekanan intrakranial bisa terlihat pada slide di bawah ini. Slide. Pada Brain Trauma Foundation Guideline 2007 dikatakan bahwa terapi ICP bila lebih dari 20. Pada yang 2016 dikatakan
tinggal 5 menit, Prof.
5 menit ya, bila lebih dari 22. Slide. Bagaimana tentang anestetik manajemennya? Ya. Untuk induksi anestesi kita seperti biasa preoksigenasi, monitor yang diukur setiap 1 menit, bila bisa diberikan propofol, tiopenton atau etomidat untuk induksi. Target tekanan darah telah disebutkan tadi, analgetik bisa diberikan fentanyl atau remifentanil, relaksan, rocuronium dengan gentle hyperventilation karena kita tahu bahwa hyperventilation akan berefek buruk pada cerebral blood flow. Next slide. Maintenance anestesinya yang baru itu dikatakan gunakan TIFA dengan propofol, dengan remifentanil atau fentanyl. TIFA sendiri atau disertai dengan konsentrasi rendah dari anestetika volatil merupakan teknik anestesi yang populer saat ini. Dan kalau bisa harus dihindari penggunaan anestetik volatil sampai dura dibuka. Itu pada bukunya Miller tahun 2020. Cerebral perfusion pressure tadi 60-70 harus betul-betul dipantau berapa end-tidal CO2-nya. Manitol tetap diberikan. Next slide. Kenapa TIFA lebih disukai dalam neuroanestesi untuk cedera otak traumatik ini? Karena propofol mempertahankan cerebral autoregulasi dan menurunkan ICP. Volatil anestetik menekan cerebral autoregulasi. Dan volatil anestetik yang diberikan lebih baik kurang daripada 1 mg karena bisa mengganggu autoregulasi dan respon pembuluh darah otak terhadap CO2. Volatil anestetik mana yang digunakan? Ternyata kita lihat saja dari efek cerebral vasodilatasinya di mana desfluran lebih besar dari usfluran dan lebih besar dari sevofluran. Slide. Ini adalah pada tentang depresi, efek depresi daripada autoregulasi oleh obat-obat volatile anestetik. Makin tinggi makin mengdepresi, dan makin tinggi cerebral blood flow akan makin meningkat. Next slide. Nah, bagaimana kalau sedang dibuka otaknya kembung gitu ya? Hentikan obat anestetik inhalasinya. Berikan bolus propofol dengan epinefrin. Mulai TIFA. Kalau tadi belum mulai TIFA, TIFA dimulai sebagai anestetik utama. Temporary hiperventilasi sampai masalah otak yang mencembung itu, bulging itu sudah dihilangkan. Next slide. Slide. Tadi telah disebutkan bahwa volatile anestetik itu bisa, bila ada peningkatan IC, masih bisa dipakai atau tidak, tapi masih bisa asal di bawah 0,5 mg. Slide. Seizure prophylaxis bagaimana? Itu hanya untuk yang penggunaan phenytoin itu tidak dianjurkan untuk mencegah late PTS, late post traumatic seizure. Next slide. Jadi pada Brain Trauma Foundation Guideline 2016 sebutkan bahwa early benefit for 1 week to prevent seizure itu tidak dianjurkan lagi. Jadi pencegahan dengan pemberian phenytoin itu hampir tidak ada gunanya. Demikian juga apa yang dipublikasikan pada tahun 2019 sama. Next slide. Next slide. Nah, bagaimana tentang rescue ICP, yaitu randomized evaluation of surgery with craniectomy for uncontrollable elevation of intracranial pressure. Dan next slide. Tentang ini adalah yang 2020 update dari dekompresi craniectomy. Karena baru dipublikasikan, karena tidak sempat dipublikasikan, keburu dipublish yang Brain Trauma Foundation 2016 itu. Tapi pada kesimpulannya bahwa yang pertama adalah elektif dekompresi craniectomy tidak terlalu berguna gitu ya. Next slide. Dan sebagai kesimpulannya tidak banyak yang berubah dari Brain Trauma Foundation Guideline 2016 itu sampai sekarang tidak banyak yang berubah. Yang terutama ditekankan adalah tentang pengaturan tekanan darah. Kalau dilakukan teknik anestesi umum untuk anestesi cedera otak traumatik itu lebih bagus dengan TIFA. Mungkin cukup sekian. Terima kasih. Wassalamualaikum warahmatullahi wabarakatuh. Slide terakhir.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you to Prof. Tatang Bisri. And then we continue in the third topic, the wonderful topic by Professor Kwek Tong Kiat. Good morning.
Good morning.
And
Yes.
Prof.
Good
Kwek
morning.
Tong Kiat from Tan Tock Seng Hospital, Singapore. And he talking about neurologic manifestation of COVID-19 and 20 minutes for your presentation. Thank you very much.
Thank you very much, Rahajo, for your kind invitation, your kind introduction. I'd like to also thank Prof. Sudadi and the organizers for the kind invitation to participate in this meeting. As has been said earlier, I think we wish we could meet in person in the usual way, but clearly we're not in the usual times. And I send my greetings to all the doctors in Indonesia and also in the region. And as we go through the pandemic. My best wishes to you. I'm sure you're all working under very challenging conditions, and we're all hoping and praying that the pandemic will be over soon. And I look forward to meeting my friends from the region face to face. And for today's talk, while we're all quite sick and tired of COVID-19, I thought that it'd be useful for us to be aware of some of the neurologic manifestations that have been reported in the literature concerning COVID-19. And we know that this pandemic has been with us for the past 1.5 years after its initial appearance in China in December 2019. And these are the data of the current state of affairs worldwide. And I put this out last night from the Johns Hopkins website. And you can see that to date, there are 192 million cases worldwide. And it's probably an underreporting. Almost 4 billion people have been vaccinated. And to date, there have been 4 million deaths. And indeed, it is a pandemic that has devastated the world, both economically and also devastated the healthcare systems worldwide. If we look at the virus, which is the SARS-CoV-2 virus, which is actually very much related to the SARS-CoV-1 virus that we encountered in 2003, the virus has a spike protein which binds to host cell receptors, which are the ACE2 receptors. After fusion, the virus gains entry into the cells, and the native RNA of the virus is released, which then replicates. And using the mechanism within the cells, go on to produce new viruses in large numbers, which are then released into the circulation and go on to spread within the host. And we know that in the vast majority of patients, 80% of them at least, the disease is likely to be milder, with 14% having more severe disease and may need to be in intensive care, though not all of them might be intubated. And 5% of patients go on to have severe disease, severe ARDS, multi-organ failure. Now we know that those who are older tend to get more severe disease, and also those who have coexisting other comorbidities are also at higher risk of having severe disease. But neurologic manifestations was something that isn't a core manifestation of a coronavirus, but is increasingly recognized to be something that does affect a significant number of patients. And this was the first report of the neurologic manifestations and was published in April last year from Wuhan, China, of a cohort that they studied retrospectively, 214 patients, of which about a third had neurologic symptoms. And if you look here, about 36.4% of the cohort had neurologic manifestations, but most of them were fairly non-specific, like headache and dizziness. And a number of them have loss of taste and loss of smell, which today we know is one of the early signs of having a COVID infection. And they reported the incidence in about 5%, having one of them, either a loss of taste or loss of smell. And you can see that in more severe type of neurologic manifestations like stroke, they reported 3%. If you compare those with more severe disease in the green box versus those with milder disease in the blue box, you can appreciate that having more severe disease increases the incidence of neurologic manifestations. And if you compare the incidence of stroke between severe and mild disease, the incidence is almost 10 times higher. So certainly it's something that wouldn't be trivial in the group of patients that we would typically manage in intensive care. Looking at a more recent report, and this was published a couple of months back this year, and it is a study out of the United States where they studied 3,055 patients from 6 centers. And you can see that they reported an overall incidence of about 80% having some neurologic manifestations, and only half of them actually having some neurologic signs. And again, you can see that they are fairly non-specific headache, syncope, although the reported incidence of either loss of taste or smell was slightly higher in about a quarter of patients. You can see that the incidence of stroke is about the same. Earlier on, it was reported at 2.8%. This is at 3%. And so it seems like it is fairly similar in the different populations that were studied. The other thing that's noteworthy in this study is that they found the odds ratio of mortality in our patients increases to 2.5 times if you have any form of neurologic manifestation. And if they have clinical signs of neurologic manifestation, actually the odds ratio of death is 6 times higher. So again, it is a sign of severity, and it also is a negative prognostic sign for our patients for mortality if they were to have some form of neurologic manifestation. This is an even more recent study, just this month, published in the Lancet, and it's a very large study, a prospective multi-center cohort study out of the United Kingdom, 302 sites with 80,000 patients recruited. While we are looking at all forms of mortality, but if you focus your attention on just the neurologic complications, you can see that they reported about 4.3% having neurologic manifestations, complications. And again, you can see that those in the older age group have a much higher incidence, almost 15-fold compared to those in the youngest age group. Closer to home, this is a study from Singapore, and we looked at our cohort of about 50,000 patients last year when we had a very large outbreak among our foreign worker population. And so these were mainly young patients and predominantly male. And we found that there were 39 cases and a much lower incidence as compared to other studies. And that's because I think we only focus on severe neurologic syndromes. For example, encephalitis, encephalomyelitis, where we have 4 patients, cerebral venous thrombosis, ischemic stroke, and intracerebral hemorrhage, for which we have 25 cases. So it certainly is a condition that cuts across all populations and affects us from both very mild to very severe disease. Now, is there a pathogenetic cause for why neurologic manifestations would feature in a COVID type infection? And indeed there is. And this diagram shows where ACE2 receptors can be found within the central nervous system. And you can see here that receptors are well expressed in the motor cortex, around the ventricles, in the substantia nigra, even in the olfactory bulb, which is what many of the patients who have loss of smell and taste. And you can see also within the brainstem. So clearly there are many sites within the central nervous system whereupon the virus could bind and gain entry into cell and spread and cause infection. So we know that from where the virus occurs and initially starts as an infection within the upper respiratory tract, and viruses in this area can easily gain access across the cribriform plate into the olfactory nerve. And this has been demonstrated in pathology studies that have isolated the virus within the olfactory bulb of patients who have succumbed to the illness. And once having gained entry into the central nervous system, the virus could spread across the synaptic gap between neurons and spread within the central nervous system once it has achieved a foothold within the CNS. Alternatively, it could gain entry into the CNS across the blood-brain barrier, having arrived at the brain hematogenously. It could infect the endothelium that forms the blood-brain barrier, or it could infect the astrocytes that help form the blood-brain barrier and thereby enter the CNS, or it could enter via infected white blood cells that then cross the blood-brain barrier, seemingly to fight the infection but actually bringing the virus into the CNS, what is known sometimes as the Trojan horse mechanism. And we know that once it has gained entry in the central nervous system, there could be direct viral invasion of neurons and spread within the CNS. We also know that the virus can infect endothelial cells elsewhere throughout the body and lead to activation of procoagulant factors and the manifestation of thrombosis, as we have seen in a 3% incidence of stroke, including cerebral venous thrombosis that was reported from Singapore. It can also lead to an immune system activation, excessive production of cytokines leading to systemic cytokine storm and the hyperinflammatory state that we do see in many of the COVID patients. Now, looking across the world at the different types of CNS infections that have been reported, this is a small study out of France, 58 patients, ICU patients, and they reported non-specific leptomeningeal enhancement for the 13 patients in whom an MRI scan was done. In 11 patients out of the total of 58, where they did perfusion studies, they found abnormalities in 100% of those patients. And they found a 25% incidence of stroke on MRI among the 13 in whom an MRI was done. Interestingly, when they measured or they tried to identify whether viruses could be found within the CSF, among the 7 in whom they had analyzed this, they did not find any virus within the CSF. Looking at another study, again, and in this case from the United States, where they look at 235 ICU patients, of whom 21% had neurologic symptoms, and of this 21%, half of them had an MRI scan done. They found on MRI, again, fairly similar cortical diffusion restriction on the DWI scans images, and also leptomeningeal enhancements, again, fairly non-specific findings, which could be findings typical of encephalitis or even having patients having seizures, hypoglycemia, or even hypoxia. So clearly nothing very specific, but definitely evidence of CNS involvement and abnormalities that at this point were not very clear what entirely they are about.
5 minutes remaining.
Thank you. And in this study out of Japan, where they studied meningitis and encephalitis, in one case, they did identify the virus within the CSF. So clearly, while it is not often found and frankly, not often measured in the CSF in many studies, but we at least know for a fact that it can be identified in the CSF. Even Guillain-Barré syndrome as a manifestation of COVID-19 has been reported, and this was from a small series from Italy where they reported 5 cases with Guillain-Barré syndrome appearing between 5 to 10 days after the onset of COVID-19. So looking at all the manifestations, it is clear and there's mounting evidence that COVID-19 is a neurotropic virus. It does cause disease within the central nervous system, although at the moment it is not the main manifestation. But there's some evidence that we are under detecting its involvement in many patients. It is still not well understood and its neuropathology not known. And I think at the moment, detection and study of these manifestations are severely hampered, firstly by underreporting, as I've said, and also often the criticality of illness and the need for deep sedation and paralysis, again, often limits neuro exam and neuro investigation, where infection control measures may sometimes prevent the performance of necessary neuroimaging to better understand this condition. So clearly, there's a lot more work to be done. And I think as we better understand what's happening in the brain, it might allow us to then provide more targeted therapies and hopefully prevent what may well be long-term morbidity in the central nervous system and the patient's cognitive function arising from this infection, which at the moment I think is under-realized and understudied. So watch this space. I think there's a lot more to come that we can learn. And lastly, let me thank you again for your kind invitation and your attention in this very short lecture. And my best wishes to all my friends in Indonesia and the region for both this meeting and in our continued fight against COVID-19. Thank you very much.
Thank you to Prof. Kwek, Tong, Kiat. I think that's important information. And I goes to the last speaker, the wonderful topic by Professor Jian with a topic, a cardiac output and cerebral blood flow connection. And 20 minutes to Professor Jian. Thank you very much.
Thank you, Sri. Am I controlling my own slides, or you are showing the slides for me? Oh, okay, I'll take that. Okay, next slide. Yeah, so I would like to thank the organizing committee for this opportunity, as well as the privilege of sharing this session with all of you. And it is indeed a very unusual time that we have to do all this across the Zoom. But hopefully I can share with you some of my thoughts on this topic, and perhaps we can think a little bit more and have a further discussion on this. Next slide. So I'll start with, next slide. I'll start with a case that I managed some time back. Of course, I simplify this case a little bit just to illustrate a point. Essentially, a 67-year-old female with background history of hypertension, and she presented with SAH, and presenting GCS was E2, V3, M5. With that is the scan. I mean, not her scan, but a similar looking scan that she had. A bit of hydrocephalus and a bit of subarachnoid blood. And because of that, we brought her to the OT and put in an EVD, and she was kept intubated after the surgery. So the GCS improved in the ICU to E3, VT, M5, and 6, and the CTA as well as the 4VA showed a left distal ICA aneurysm. On day 3, she underwent endovascular coiling, and after coiling, she actually improved, and her GCS is E4, VT, M6. So she was extubated shortly after that, and as per our protocol in the ICU, we perform daily TCDs. Next slide. And unfortunately, next slide. Unfortunately, we don't have very good TCD windows, but whatever we got show a slightly elevated MCA velocity, 120, 150, and the lean gut ratio about 3 to 4. Not always consistent, but that's the whereabouts that we have. And so we, as part of our triple H therapy, we started noradrenaline, keeping the systolic blood pressure between 160 to 180 millimeters mercury. And of course, as we usually keep our patient well hydrated, and despite all that we are doing, she was not getting better. She was by day 8, she was more drowsy, and she was not moving the right side as much, and had some weakness on the right. So we did an angio and found to have vasospasm. So we administered IA nimodipine, and after which she woke up a little bit, still a bit slow. And because of that, we bumped up our target, because we knew that that there was underlying vasospasm, and we bumped up our target to 160 to 200 millimeters mercury using noradrenaline. And noradrenaline is running like closer to 0.5 mics per kilo per minute. Still, she is still fluctuating with, sometimes good, sometimes not so good. Next slide. Next slide. So we decided I decided to add dobutamine to this patient, and I also put on a flow track monitoring to sort of guide me in my vasopressor administration, and with the addition of dopamine, we were able to wean down the noradrenaline a little bit, and we kind of lower my target to 160. And she showed clinically she was more awake, and we were able to get consistent M6, even though there is still slight weakness on the right. And the TCD, perhaps there's some improvement, not remarkable. And because of clinical improvement and some slight TCD improvement, we started to wean the dobutamine, and we continue to maintain the blood pressure with noradrenaline. By day 15, day 16, she started to get a bit drowsy again. CT scan was done. There's nothing, no hydrocephalus. There are small areas of infarct, and so again, consistent with a picture of vasospasm. So we push up the noradrenaline again. And there's not much improvement. So we started dobutamine once again on day 17, and over the next few days, she started to improve. And we are able to then wean down the dobu and the noradrenaline, and by then she was a lot more stable, with remaining residual weakness of the right side, and we were able to send her out of the ICU a few days later. Next slide. So perhaps you'll be skeptical about what I've just shared. But in my mind, perhaps the dobutamine improved the cardiac output, and perhaps that has made some difference to this patient. And is it due to increased perfusion pressure that is causing the difference, or is it the heart contractility leading to increased cardiac output that leads to it? These are some of the things that I wonder. All right, and so for the rest of the lecture, I will share with you some of the evidence and some of my thoughts. What are some of the unknowns, and I'll leave you with that. All right, next slide. Okay, so using a dobutamine to enhance perfusion to the brain in subarachnoid hemorrhage is not new. There are evidence showing that addition of dobutamine to improve perfusion to the brain is as shown in these papers. But what is interesting here is that, is this a function of improving the mean arterial pressure, in other words, cerebral perfusion pressure, or is it an independent effect of the increase in cardiac output that leads to this increase in cerebral? So this is the question that we will have to ask ourselves, and I will perhaps try to answer some parts of it. Next slide. All right, because if you look at the guideline on management of aneurysmal SAH, there is mention of hypertension and euvolemia, obviously, but there is no mention of cardiac output specifically. Next slide. So where does all this lead us to? There is obviously quite a fair bit of interest recently, all right, as well as a debate on the role of cardiac output on cerebral blood flow. Next slide. And I shall, through this short 10-15 minutes, share with you a little bit of the neurophysiology and what is the controversy, or what is the the new thinking now, and share with you some quick evidence, as well as what is the underlying hypothesis, as well as finally I'll share with you what I think we can do in our clinical practice. Next slide. So as a revision, we know that the preservation or restoration of the cerebral blood flow is the most important fundamental thing that we need to preserve when we talk about neuroprotection. Next slide. Yeah, and we also know very well about our Poiseuille's law, our Ohm's law. Essentially, the flow is dependent on the differential pressure, as well as the radius, which is the lumen, in other words, the diameter of the vessels. And the other formula that has been shown many times over the course of this symposium as well is that CPP is a function of MAP MAP minus the ICP, and the cerebral flow depends on, is affected by the CVR, which is the resistance. Next slide. Okay, again, a very, very familiar curve. Prof. Tatang has also mentioned about the lower limits of autoregulation. Even though 50 and 150 is sort of the idealized curve, we all know that it is not so ideal in our patients. And I won't go into great detail of this, but we all know the bad thing about hypotension. Hypertension, increasingly there is a greater awareness that hypertension is compared to hypotension is better tolerated, but still we will try our best to keep the blood pressure within the autoregulatory range. Next slide. However, in recent times, it's increasingly it's been recognized that it is a lot more than that. It is much more complicated, and the diagram shown on the slide is a theoretical construct of perhaps, it's the autoregulation curve that we know of is not so simple. It can also be affected by the cardiac output, because it is quite intuitive, isn't it, that the brain receives a large part of the cardiac output, and therefore the cardiac output must play an important part to cerebral blood flow. All right, and next slide. So looking into the literature, is there evidence of the cardiac output affecting the cerebral blood flow independent of the blood pressure? So these are the types of studies. There are many, volunteer studies where if I can, no, you can't see, right? Okay, these are healthy volunteers where they have a negative pressure suit, and by using the negative pressure suit, they are able to create a negative pressure at the lower parts of the body, creating a reduction in the venous return, leading to a reduction in the preload and therefore the cardiac output. And what they found by measuring the cerebral blood flow, they find that with a reduction in the cardiac output, there is a corresponding reduction in the cerebral blood flow, with or without a drop in mean arterial pressure. All right, next slide. And within a short period of time, there is no change in CMR to account for that the reduction in the cerebral blood flow. And a sort of a summary of this kind of studies in healthy volunteers, they found that for whenever there is a reduction in the cardiac output, there is a reduction in the cerebral blood flow. And correspondingly, when there is an increase in cerebral cardiac output, there is an increase in cerebral blood flow. Next slide. What about those patients who have chronically reduced cardiac output? So chronically reduced cardiac output, like in congestive heart failure, they found that in patients with chronic poorly controlled patients with heart failure, their measured cerebral flow is actually lower than normal people. And if you optimize the cardiac function and you measure the cerebral blood flow, again, there seems to be an increase in cerebral blood flow. Again, this seems to be, again, independent of the blood pressure of these patients. Next slide. A little bit more indirect from there is that the cardiac output does play a part in the health or function of the brain. While this is not directly related to cerebral blood flow, but it's been recognized that patients with poor heart function have a higher prevalence of cognitive dysfunction. It could be multifactorial, like the picture I've shown you, but could it be also that due to reduction in the cardiac output, there is a reduction in cerebral blood flow? Next slide. And what is more alarming and exciting was the use of phenylephrine and ephedrine. So this is a study sometime back, 2011, and using comparing phenylephrine versus ephedrine, knowing that ephedrine is a pure alpha agonist causing vasoconstriction without any effect on the heart, versus ephedrine, which has mixed effects and therefore both causes increase in blood pressure as well as increase in cardiac output. And using near-infrared spectroscopy measuring the cerebral oxygenation, they found that using ephedrine causes an increase in blood pressure, expected effect, causes a no drop in cardiac output on the panel on the right, if you can see it. And they found that the oxygen saturation of the brain is maintained. Whereas if you use phenylephrine, you get an increase in blood pressure, but you drop the cardiac output and correspondingly drop the cerebral oxygenation. So of course, it is something that gets a lot of people excited. Next slide. Another similar study shortly after that in carotid artery endarterectomy. Obviously, this is a surgery where perfusion pressure, maintaining cerebral flow is crucial, and as similar results, drop of cerebral oximetry readings using phenylephrine compared to ephedrine. So this is very exciting and led to many studies. Next slide. More recent studies, however, did not confirm the same findings. In this Pepper study, again, carotid endarterectomy, again, oxygen saturation using phenyl and ephedrine. Similar sort of result, but did not reach any statistical significance. Next slide. Another very recent study published in ASA, comparing again ephedrine and phenylephrine. This time, instead of using a cerebral oximetry, they use PET scan in brain tumor surgery. They found again that, that there is no real difference, even though in the contralateral region, ephedrine was associated with increased cerebral blood flow. All right, next slide. So you may be very confused, as I was when I was first looking at this. Okay, so we know that cerebral flow. This is again a revision. Driving pressure versus the CVR. If we think that cardiac output plays a part and independent of the blood pressure, then cardiac output must affect the CVR in some ways. Next slide. So what's the postulation here? The postulation is that, number one, when there is first of all, there's a recognition that the sympathetic nervous system plays an important part. There is extensive SNS innervation of the extracranial vessels. Therefore, when there is a reduction in the cardiac output, there is a compensation in the rest of the body trying to vasoconstrict. And there is also vasoconstriction of the extracranial vessels. And that can in itself lead to a reduction in the cerebral flow. Two is that arterial pulsatility, the fact that there is pulsatility in our blood flow, and that pulsatility as it stretches the arterial wall causes a vasodilatory effect. In other words, the fact that there is cardiac output itself, independent of the blood pressure, causes changes in the CVR, leading to changes in the cerebral blood flow. Okay, next slide. Which is why this is the picture I've shown you earlier. This is from Adrian Gelb's group a few years back, but this is again trying to tie things together. Again, it's also idealized. It's not it is trying to try to put everything together in one slide. What are the various effects on the cerebral blood cerebral flow autoregulation curve that we are also familiar with, and starting to throw doubts into it. Next slide. Next slide. So obviously this is highly complex and not fully understood. CBF is regulated by multiple mechanisms, all right, and with the aim of matching supply versus demand. And cardiac output is increasingly recognized as perhaps one of the processes that contribute to the CBF. All right, we don't know exactly how, but we think that there is an effect, like what I've shared with you, on the cerebral resistance vessels. And next slide. Okay. What we do not know is that it is, again, from the earlier slides that I've shared, it is not so intuitive and not so physiologically robust, the explanation at this point in time. Many of the studies were small. You can also argue whether NIRS is good enough technology to measure cerebral blood flow versus the gold standard TCD. And unanesthetized volunteers may not necessarily reflect that of an anesthetized surgical patient.
Minutes remaining?
10 minutes or 5. I'll be done soon, not to worry. and different drugs exert effect on the cardiovascular system differently. And a lot of times it's hard to tease the cardiac output from the MAP away independently. All right, so also there is, at this point in time, lack of evidence supporting outcome, which is why I shared with you the SAH guideline does not talk about cardiac output. It's talking about optimizing the pressure, and we also have no idea of whether the choice of vasopressors really affecting the outcome. Even though I've thrown a question to, rather than giving you an answer regarding phenylephrine and ephedrine, but it is a lot of things that we do not know yet. Next slide. So now what? All right, perhaps allow me to just conclude this by going to the next slide. Next slide, yeah. So I think what is important or rather the take-home message from this 20 minutes that I've shared with you is that cerebral circulation obviously is very complicated, and cardiac output is perhaps one of the factors that you have to consider, because whenever there are changes in the cardiac output, be it from loss of preload, be it from a change in the systemic vascular resistance, or change in the hydration status or sympathetic state, or is it the drugs that we are giving, all that can affect cardiac output as well as the blood pressure, and the management of simplistically managing blood pressure. In other words, if the patient is dry and dehydrated and therefore the blood pressure is low, giving phenylephrine in this situation obviously treats the number, allows you to achieve a greater mean arterial pressure, but does not address the problem, because of a reduction in the preload, your cardiac output will be low, even though you have a reasonable pressure. That in itself perhaps is not enough to ensure that the cerebral blood flow is adequate. All right, and next slide. And therefore, it is important for us to understand the physiological relationships besides the blood pressure and perhaps the cardiac output as well. And like I've just shared with you, the various etiology of cerebral perfusion, reduction in cerebral perfusion must be explored, and perhaps using getting more information of this will then sharpen our clinical acumen. For example, goal-directed fluid therapy or cardiac output monitoring, like in the case that I've shared with you, using the flow track, I was able to at least know that my cardiac output is within a certain range, my SVR is within a certain range, that I've not overly vasoconstrict that patient, so that at least I can titrate my medication a little bit better. All right, last slide. So again, in summary, it's important for us to appreciate neurophysiology, not to throw them away. I think they still forms the basis of our understanding of how things work. Cardiac output is increasingly recognized to play a key role in the regulation of cerebral blood flow, even though the mechanism is not totally understood. So besides pushing the CPP, we should consider optimizing cardiac output, especially if driving CPP alone is not achieving the results that we want. Consider optimizing the hemodynamics as a whole, not just the blood pressure in isolation, but together with the cardiac output. Unfortunately, or rather, at this point in time, there is no robust evidence to suggest that there is a direct and independent relationship of cardiac output and cerebral flow. Next slide. So I thank you for your attention and hope that and I would also like to thank the organizing committee once again for the privilege and the opportunity. Thanks.
Sorry.
Thanks.
Thank you very much to my Professor Jian.
Thanks.
The wonderful presentation. And thank you to all speakers to sharing your knowledge and multi information can pick up from the every topics. And I think multi-beneficial effect to neuroanesthesia works. And then we closing the meeting and give big applause to all speakers. Thank you very much.
Thank you for all moderators and all speakers for the great presentation. Maybe we can continue with the Q&A question, one or two questions. It probably have more time. Please, Dr. Sri Raharjo as a moderator to guidance the discussion of the symposium.
Oh, kalau di plenary lecture ada diskusi. Ya, Pak, coba di
plenary biasanya nggak ada diskusi kan?
Plenary nggak ada diskusi, Mbak.
Siap, Dokter.
Mute.
So I think in the plenary lecture, without question and answer, and I think I close the meeting. Okay, thank you very much to committee.
Okay, thank you for moderator and all speaker. Before closing the plenary lecture session, the moderators and all speaker are requested for the photo session, please. Please, Dr. Sri Raharjo, Dr. Bambang, Prof. Tatang, Prof. Kwek, Tong, Kiat, and Prof. Jian. We have take some photo shoot.
Okay.
Cheers. 1, 2, 3, trees. Once more. 1, 2, 3, cheers. Okay, thank you.
Thank you.
The plenary session has finished. And for the next symposium, we will continue with the symposium 1 with the topic eras in neuroanesthesia at 10 p.m. until 12 p.m. Jakarta time. And symposium 2 with the topic traumatic brain injury at 1 p.m. until 3 p.m. And symposium 3 with the topics brain tumor at 3 until 5 p.m. After this plenary lecture, there is a flashback video year by year for the Indonesian Society Neuroanesthesia and Critical Care Annual Scientific Meeting. And for the audience, please keep join at the same link. Don't go anywhere and stay tuned. Thank you for the participant, for our audience, and see you again in the next symposium. Wassalamualaikum warahmatullahi wabarakatuh. God bless you.
Waalaikumsalam warahmatullahi wabarakatuh.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Good morning for college and all audience. Welcome back again to the 50th National Congress of Indonesian Society Neuroanesthesia and Critical Care, 7th Joint Symposium of Neuroanesthesia and Critical Care Indonesian Singapore, and 6th Biennial Symposium of Anesthesia Complication virtually. Let me introduce myself first. My name is Hening Tirta Kusuma Wardani. As a Master of Ceremony in this entire series of event today, before we start this symposium, allow me to need the attendance technical instruction of the symposium participant. The first attendance ID in this webinar must use the real name, not device name or the institutional name. The second, attendants are strongly encouraged to mute during the webinar, and all attendants who take part in the webinar can ask a question by writing their name, institution of origin, and question briefly. All attendants have to fill the registration, just one for all the symposium that will be held during this event, and all attendants who do not fill the registration link will not get a certificate. Today we have 4 sessions, the first plenary lecture that have previous event, and the symposium 1 with topics ERAS and neuroanesthesia, symposium 2 with the topics traumatic brain injury, and symposium 3 with the topics brain tumor. And now we were starting the symposium 1 with the topic ERAS in neuroanesthesia. Welcome to the speaker and moderators, the Honorable, the first, Dr. Rudi Prihartono, Master of Health, Master Scientific Medicine, Anesthesiology Specialist, Neuroanesthesia Consultant, Fellow Internal Pain Management from Dr. Margono Hospital, Purwokerto, Indonesia as a moderator. Dr. Sudadi, Anesthesiology Specialist, Neuroanesthesia Consultant, Anesthesiology Regional Consultant from Dr. Sarjito Hospital, Yogyakarta, Indonesia, with the topic ERAS and Fast Track in Neuroanesthesia. And the second speakers, Dr. Nazaruddin Umar, Anesthesiology Specialist, Consultant Neuroanesthesia from North Sumatra University Hospital, Medan, Indonesia, with the topic Management of Intractable Intracranial Hypertension, and also Prof. Si Jinjiang from Tan Tock Seng Hospital, Singapore, with the topic Eras in Neurosurgery. Does the anesthesia techniques matter? And Dr. Chong Chin Tet from the Tan Tock Seng Hospital, Singapore, with the topic Eras for Neurosurgery, a perspective from Singapore, including scalp block as an adjuvant technique in neuroanesthesia. And let me telling curriculum vitae from the Dr. Rudi Prihartono, Master of Health, Master Scientist, Medicine Scientist, Anesthesiology Specialist, Neuroanesthesia Consultant, Fellow International Pain Management, Dr. Rudi Prihartono at the 2002 graduated from the Medical Faculty Islamic Sultan Agung University Semarang, and the 2004 graduated from the Master Service Policy and Management. 2007 graduated Master of Biomedic Science, University of Diponegoro. 2008 graduated Anesthesiology Specialist from University Diponegoro, and 2012 graduated Neuroanesthesia Consultant from Pajajaran University. And the last position as a Dean, Medical Faculty, Jenderal Sudirman University, Purwokerto, Indonesia. Next, we please Dr. Rudi Prihartono, Anesthesiology Specialist, Consultant Neuroanesthesia, Fellow International Pain Management, as moderator to take over the guidance of material session and discussion of the symposium. Time is yours, Dr. Rudi.
Okay. Thank you, MC, for the opening, and let me take over the event for the next 60 minutes. Yeah. Okay. Thank you to all of the participants who came this morning at the 15th INA-SNACC, 7th NACC Indonesia, Singapore, and 6th SOAC Symposium and Congress. May we all be in good health and always in the protection of God. The current pandemic condition make us more creative and have a breakthrough in various scientific activities. And so the topic in this session is an interesting topic, I think, for the discipline of anesthesiology, because it relates to fast and good recovery after surgery. Today, we are going to feature some really great speakers. We give our highest appreciation for the time and opportunity given to us for the fairness of sharing knowledge and experiences. There are 4 speakers, Dr. Sudadi, with the topic Eras and Fast Track in Neuroanesthesia, and then Dr. Nazruddin Umar with the management of intractable intracranial hypertension, and Dr. C. Jian again, Eras in Neurosurgery. Does the anesthesia technique matter? And the last, Dr. Chong Chin Tet, Eras for Neurosurgery, a perspective from Singapore, including scalp block and as an adjuvant technique in neuroanesthesia. The last with closing with the discussion. Firstly, I think time for Dr. Sudadi. As we know, the speaker given 20 minutes, and after that, we are the end of our session with 40-minute discussion. Communication carried in two languages, in Indo Bahasa and in English. Okay. I think Dr. Sudadi, the time is yours as a host presenter. Thank you. Please, Dr. Sudadi.
Okay. Assalamualaikum warahmatullahi wabarakatuh. Nice introduction. Thank you, Dr. Rudi. And the next, I will use Bahasa Indonesia. It's for issue for me, and I think the audience is much in Indonesian, so must to understand. Ya, Bapak Ibu sejawat sekalian, pada hari ini saya mendapatkan tugas untuk menyampaikan Eras dan Fast Track di Neuroanestesi. Sebetulnya Fast Track itu adalah awal mula dari ERAS ya. Jadi pada awal yang pada dahulunya dikenal fast track untuk pembedahan yang singkat dan terencana. Ya. Jadi pada hari ini saya akan menyampaikan mengenai hal tersebut. Next slide. Ya. Sebelumnya Mas. Sebelumnya atau saya dari saya saja. Halo. Sudah kelihatan? Sudah kelihatankah?
Sudah.
Sudah kelihatan.
Ya, deh. Ya, saya akan menyampaikan mengenai fast track di neuroanestesi. Seperti kita ketahui bahwa fast track ini merupakan awal mula dari ERAS sebetulnya, Enhanced Recovery After Surgery, yang dahulunya fast track ini untuk prosedur-prosedur yang singkat yang bisa kita planning untuk cepat pulang dari rumah sakit. Ya. Beberapa topik yang akan saya sampaikan setelah nanti pengantar, saya akan menyampaikan mengenai secara umum gambaran ERAS di neuroanesthesia atau pembedahan bedah saraf, yang kemudian dilanjutkan dengan komponen dari ERAS. Nah, sebetulnya ini tadi sudah dibahas oleh Dr. Bambang pada waktu plenary session, ya, yaitu preoperatif, intraoperatif, dan postoperatif. Ya. Seperti kita ketahui bahwa ERAS ini merupakan pendekatan multidisipliner peroperatif ya, yang bertujuan untuk meminimalkan efek dari pembedahan yang kita tahu bahwa stres pembedahan itu cukup tinggi, dan kalau ini dikelola dengan baik, pasien akan recovery ataupun akan pulih sadar dengan lebih cepat dan kemungkinan akan bisa pulang dengan lebih cepat. Dan sebetulnya ini adalah multidisiplin, multimodal yang terintegrasi berdasarkan basic knowledge yang mungkin lebih simple dengan pengelolaan yang lebih baik untuk mendapatkan outcome pembedahan yang baik. Ya. Dan fast track yang merupakan cikal bakal dari ERAS ini adalah pengelolaan peroperatif untuk suksesnya sebuah pembedahan. Saya kira. Mengenai ERAS sendiri sebetulnya awalnya dikemukakan oleh Henry Kehlot pada tahun 1997, dan juga tadi sudah disampaikan oleh Dr. Bambang sebelumnya bahwa awal mulanya ini berawal dari pembedahan kolorektal yang kemudian berkembang, dan ini tujuannya adalah untuk outcome dari pembedahan. Ya. Sedangkan di neuroanesthesia atau di bedah saraf sendiri ini merupakan konsep yang baru sebetulnya, dan tentunya ini sangat berhubungan dengan pengelolaan peroperatif. Ya. Jadi, kemudian pada tahun 2001 ini dibentuk studi grup mengenai ERAS, dan 2010 dibentuk grup yang society dari ERAS sendiri, dan sekarang ini ERAS sudah ada organisasi di dunia ya, yang lebih komprehensif saya kira. Ya. Oke. ERAS di neurosurgery ya, ini sangat berhubungan sekali dengan kondisi pasien ya. Jadi morbiditas maupun mortalitas pasien ini sangat berhubungan dengan kondisi pasien, dan outcome tentu berkorelasi secara eksponensial dengan pengelolaan dari perioperatif. Kalau perioperatifnya tidak baik, tentu outcome-nya menjadi sangat tidak baik ya. Dan ini memerlukan suatu protokol. Kalau sekarang kita bilang mengenai merupakan clinical pathway multidisiplin. Jadi misalnya anestesi mengerjakan apa, bedah mengerjakan apa, kemudian psikolog mengerjakan apa dan sebagainya. Ini terintegrasi. Nah, dengan hal tersebut secara signifikan akan memberikan outcome yang sangat baik. Ya, di next-nya kemungkinan di kemudian hari bahwa praktek anestesia ini akan mengarah ke ERAS, dan di sini tentu akan mengurangi pembiayaan, mengurangi komplikasi, mengurangi lama perawatan dan sebagainya ya. Dan kita lihat bahwa keuntungan dari ERAS ini kalau kita lihat akan mengurangi length of stay dari 7 hari sampai 17 hari ini di bidang neuroanestesi. Kemudian komplikasi anestesi juga akan berkurang dari 27% menjadi 7%. Kemudian readmisi juga akan turun, dan juga mortalitas juga akan turun secara signifikan di sini. Ya, nah untuk pengelolaan ERAS sendiri ini memerlukan stakeholder. Dan stakeholdernya ini ada yang direct langsung ya, seperti seperti dokter bedah, dokter anestesi, perawat dan sebagainya. Kemudian pasiennya sendiri tentu, dan juga stakeholder yang tidak langsung seperti manajer, kemudian membayarnya siapa dan sebagainya. Ini kalau antara yang direct dan indirect ini berkolaborasi akan menyebabkan atau akan menghasilkan ERAS yang cukup baik ya. Nah, sekarang apa saja sih komponen daripada ERAS ini? Seperti ketahui bahwa komponen ERAS ini meliputi preoperatif, intraoperatif, dan postoperatif. Tadi sudah disampaikan oleh Dr. Bambang sebetulnya. Dan untuk preoperatif, ya, saya akan sampaikan ini mengenai rekomendasi dari ERAS ini berdasarkan suatu meta-analisis. Ini disampaikan melalui jurnal Clinical Neuroscience, Enhanced Recovery After Surgery, khususnya di bidang craniotomy. Misalnya di setiap kasus ini sebetulnya mempunyai satu protokol. Nah, ini yang disebut ERAS-nya. Ini dari Mid-Lancet ada 22 item mengenai ERAS, kemudian meliputi 551 reference, kemudian didapatkan 25 reference, dan ada 67 total reference yang diikutkan, ada 28 yang merupakan RCT, 16 systemic review, 6 post-operative study, dan 9 review artikel. Dan ini menghasilkan suatu rekomendasi untuk tata laksana dari ERAS di bidang neuroanestesi. Untuk yang pertama, preoperative care. Ya, di preoperative care ini meliputi konseling, kemudian bagaimana pemenuhan nutrisi, kemudian bagaimana pengaturan untuk bukan pengaturan, ya mencegah ataupun bagaimana minum alkohol maupun merokok, kemudian pencegahan trombofilaksis dan antimikrobal. Ya. Kita ketahui bahwa konseling preoperatif ini akan membantu pasien untuk memahami kondisinya, dan ini akan membantu pasien untuk proses selanjutnya menentukan intervensi apa, nah, dan tentu akan meningkatkan kenyamanan ataupun persepsi daripada pasien untuk pembedahan itu sendiri. Ya, sehingga ini jelas bahwa kesiapan dari pasien akan menjadi lebih baik. Ya. Edukasi yang diperlukan ini merupakan bagaimana kondisi pasien aktualnya, kemudian rencana tata laksana yang akan dilakukan, risiko pembedahan atau anestesi, dan outcome serta prognosis yang akan terjadi. Nah, kesemuanya ini kalau disampaikan pada saat konseling, pasien akan lebih memahami dan lebih siap. Ya. Dan ini rekomendasinya strong ya. Jadi, dan kita tahu bahwa dengan konseling yang baik, tentu pasien akan lebih nyaman. Ya. Kemudian bagaimana dengan nutrisi? Ya, status nutrisi ini sangat berhubungan dan merupakan prediktor dari mortalitas serta lama rawat inap di rumah sakit. Nah, pemenuhan kebutuhan nutrisi sebelum operasi ataupun sebelum pembedahan, di mana ini nutrisi imun akan meningkatkan respon dari sel imun, kemudian mengurangi inflamasi dan juga mengurangi stres oksidatif. Nah, hal inilah yang kemungkinan akan menyebabkan outcome dari pembedahan ini menjadi lebih baik, dan ini rekomendasinya cukup baik. Ya. Kemudian untuk merokok, ya, seperti kita ketahui bahkan untuk bukan hanya di neuroanestesi, tetapi secara umum bahwa merokok ini akan menyebabkan risiko komplikasi di pernapasan, dan penghentian merokok selama 1 bulan ini akan mengurangi morbiditas ya, postoperatif, kalau kemudian juga akan mengurangi komplikasi pulmonari ya, dan komplikasi pada saat recovery ya. Ini rekomendasinya adalah kuat ya. Kemudian bagaimana mengenai puasa? Hampir di semua pembedahan merekomendasikan bahwa sampai 2 jam sebelum operasi ini preloading karbohidrat sangat membantu. Ya, jadi sampai 2 jam sebelum operasi itu masih memungkinkan pasien untuk diberikan minuman air karbohidrat. Ya, selama ini ada yang tetap gagah menyampaikan puasa 8 jam. Ya, kalau makanan padat ya, tapi kalau minuman clear water masih 2 jam sebelum operasi masih diizinkan. Ya. Dan ini tentu bahwa intake karbohidrat akan menurunkan resistensi insulin, ya, juga akan meningkatkan kenyamanan daripada pasien tidak merasa letih, capek, ya, dan juga pasca operasi tidak kelaparan. Ya. Kemudian ini sudah terbukti bahwa minum 2 jam sebelum operasi ini tidak ada risiko untuk terjadi aspirasi, ya. Dan juga akan menyebabkan pulihnya fungsi daripada GI tract. Ya. Rekomendasinya adalah kuat ini, strong. Ya. Kemudian untuk trombofilaksis, ya, kita tahu bahwa pada kraniotomi ini termasuk high risk untuk terjadinya trombosis. Nah, dan kalau terjadi tentu akan menurunkan quality of life. Nah, di sini penting bahwa baik mechanical maupun pharmacological kita menghindari terjadinya trombosis ini. Nah, kita tahu bahwa pembedahan kraniotomi sebetulnya pembedahan yang berisiko terjadi bleeding yang besar. Ya. Kemudian untuk antimikrobal ini untuk preoperatif, ya, kita membatasi untuk scalp shaving, jadi sebisa mungkin untuk tidak dilakukan shaving. Ya, untuk kemudian diberikan cefasolin, proklanotomi. Ya. Ya, ini rekomendasinya walaupun lemah tapi sebetulnya. Oke. Bagaimana untuk intraoperatif? Tadi sudah dikemukakan intraoperatif ini meliputi pemakaian obat-obat intravenous maupun inhalasi, analgesi dan sebagainya. Untuk yang pertama, ya, intraoperatif dengan analgetic scalp infiltration atau post scalp block ini benefitnya banyak sekali, akan mengurangi, akan menstabilkan hemodinamik setelah operasi, mengurangi pemakaian obat-obat opioid, mengurangi ya post operative pain dan juga neuropathic pain. Ya. Kami di Sarjito sudah mengerjakan scalp block ini dan kita sudah melakukan research untuk pemakaian opioid durante operasi dan juga untuk pains after craniotomy dan juga cost effectiveness. Jadi dari ketiga riset tadi membuktikan bahwa selama operasi pemakaian opioid sangat kurang. Jadi ini berkurangnya itu hampir lebih dari 50%. Ya. Dan juga untuk post operatif. Ya. Dan secara keseluruhan biayanya juga turun cukup drastis. Ya. Dan di sini meta-analisis menunjukkan bahwa scalp block ini akan menurunkan fast pada 1 jam post operatif dan juga menurunkan pemakaian opioid pasca tindakan craniotomy. Dan rekomendasinya di sini baik ya, strong ya. Kemudian untuk anestesinya sendiri seperti apa? Jadi tentu pemakaian obat-obat yang cepat wash out yang menyebabkan rapid recovery anestesi diperlukan. Jadi obat-obat yang short acting ini sangat dimungkinkan. Kemudian di sini akan diharapkan akan pulih secara neurologis lebih awal dan juga komplikasi intracranial lebih cepat dilakukan evaluasi kalau pasiennya cepat bangun. Dan juga tentu pasien akan cepat untuk pulang ataupun keluar dari rumah sakit. Ya. Nah, untuk intraoperatif sendiri yang bisa kita lakukan adalah bahwa TIFA maupun volatil sebetulnya tidak ada perbedaan yang bermakna. Jadi tidak ada yang lebih superior, walaupun di beberapa kondisi ini intravenous kadang-kadang lebih menyebabkan slack brain ataupun relaksasi otak yang lebih baik. Ya. Kemudian penggunaan N2O ini mestinya dihindari karena akan meningkatkan cerebral metabolic rate, meningkatkan cerebral blood flow, meningkatkan ICP, meningkatkan kejadian dari post-operative nausea and vomiting. Kemudian pemakaian M.Kes 4 ini mungkin ya, next session nanti akan ada pembahasan khusus mengenai M.Kes 4. Baik M.Kes 4, dextromethorphan, lidocaine dan sebagainya ini cukup bagus. Ya. Ketamin walaupun mempunyai risiko halusinasi kalau pemakaiannya cukup banyak, sebetulnya karena prinsip kerjanya sama dengan M.Kes 4 ini juga merupakan brain protection dan untuk analgesi cukup baik. Ya. Nah, untuk awake craniotomy untuk tumor-tumor tertentu merupakan suatu pilihan. Ya. Jadi sebetulnya baik TIFA maupun inhalasi sebetulnya sama saja, ini tidak terlalu berbeda bermakna. Ya. Kemudian untuk analgesi, yang saya ngebut, kita harus menghindari obat-obat dengan penggunaan opioid yang berpanjangan. Jadi kalau dengan kombinasi scalp block, opioidnya sedikit, analgesinya cukup bagus. Ya. Dan ini juga mengurangi risiko prolong sedasi, miosis dan sebagainya, maupun evaluasi pos operasi. Jadi kita menggunakan obat-obat meminimalkan penggunaan opioid ini, walaupun kita tahu bahwa opioid ini cukup baik. Ya. Kemudian kita tahu bahwa NSAID sebetulnya cukup efektif, ya, walaupun ada risiko terjadi bleeding. Pregabalin ini akan menurunkan kecemasan dan cukup baik dipakai. Dan first line-nya sebetulnya ada acetaminophen. Ya. Kemudian untuk terapi cairan Durantop, ya, ini sedapat mungkin kalau dulu dry pembedahan neuroanestesi kita harapkan sedikit dehidrasi atau pembedahan kering tidak terjadi overload. Tapi ternyata bahwa di riset yang sekarang itu luarannya bahwa kalau terjadi dehidrasi itu angka mortalitas 6 bulan kemudian ini cukup tinggi. Nah, ini sudah ada riset yang dilakukan. Jadi idealnya adalah balance. Jadi zero bridge balance. Oke. Kemudian untuk temperatur sebetulnya pascanya ini antara 30 antara hipotermi maupun normotermi mortalitasnya tidak terlalu jauh berbeda. Rate-nya 35% sama 36%. Jadi kalau bisa ya jangan tidak terjadi antara hipotermi maupun normotermi. Ini akan menjadi baik. Jadi kita tahu bahwa hipotermi ini akan menyebabkan perpanjangan dari neuromuscular block, sehingga pada kasus-kasus tertentu harus kita hindari. Ya, kemudian masih di intraoperatif sebaiknya kita mengusulkan untuk minimal invasif. Kalau misalnya bisa SLTH, endoskopik itu benefitnya akan lebih banyak karena secara kosmetik maupun post operatif pain itu lebih ringan dan tentu keluar dari rumah sakit akan lebih cepat. Ya. Kemudian untuk post operatif, nah, ini meliputi PONV. Nah, kita tahu bahwa bersama pembedahan ini PONV. Nah, kemudian pemasangan DC kateter juga merupakan hal yang urgent untuk kita evaluasi sedini mungkin untuk bisa di-AF. Ya. Kemudian pemakaian pemberian nutrisi dan mobilisasi yang awal ini cukup bagus. Rekomendasinya untuk PONV, insidensi cukup tinggi, 47% di kraniotomi. Rekomendasinya kita bisa menggunakan serotonin antagonis reseptor dan plus dexamethasone. Ya. Nah, ini rekomendasinya strong ya. Kemudian untuk DC, ya, kalau sedini mungkin untuk AF karena akan risiko infeksi dan mobilisasi yang cepat ini akan outcome-nya lebih baik dan rekomendasinya moderate ya. Kemudian untuk nutrisi kita tahu bahwa pengurangan nutrisi 10 kilokalori per kilogram akan berakibat meningkatkan mortalitas rate sampai 40%. Jadi kalau bisa nutrisi ini sesegera mungkin untuk bisa diberikan supaya recovery-nya lebih cepat ya. Ya. Sama tadi bahwa nutrisi dan early mobilisasi ini mempunyai benefit, tidak terjadi trombosis dan juga otot-otot akan tidak cepat menyusut, length of stay-nya akan turun ya. Dan ini bisa difasilitasi dengan pain management yang adekuat dan PONV yang terkontrol dengan baik ya. Kalau pain manajemennya adekuat, tentu pasiennya bisa mobilisasi dengan cepat ya. Oke, sebagai kesimpulan pada sesi ini bahwa ERAS ini merupakan suatu tindakan multidisiplin, multimodal, dan tentu tadi sudah saya sampaikan perlu suatu protokol dan tujuannya adalah untuk meningkatkan outcome. Jadi walaupun mungkin kalau sekarang falsafahnya fast track itu cukup 5 hari pulang gitu, tapi sebetulnya fast track di bidang neuroanestesi mungkin tidak 5 hari, mungkin lebih, tapi tergantung dari operasinya. Jadi setiap protokol akan mempunyai outcome yang berbeda. Setiap tindakan harus mempunyai protokol. Inilah yang kita harapkan dari ERAS. Terima kasih. Assalamualaikum warahmatullahi wabarakatuh.
Terima kasih Dr. Sudadi atas presentasinya. Thank you Dr. Sudadi for your presentation and sorry for the inconvenience to all participants due to the very background sound. Mohon maaf atas ketidaknyamanannya atas suara di belakang Dr. Sudadi selama presentasi. Berikutnya langsung pembicara berikutnya adalah Dr. Nazaruddin Umar dengan topik Management of Intractable Intracranial Hypertension. Ini adalah CV dari Dr. Nazaruddin Umar. Beliau saat ini adalah dosen dan juga staf di Rumah Sakit USU. Ya. Untuk waktu dan tempat, kami persilakan Dr. Nazaruddin Umar selama 20 menit. Silakan Dr. Nazar. Monggo, Dr. Nazaruddin. Dr. Nazaruddin. Oh, suaranya nggak muncul. Dr. Nazaruddin, now it's your turn. The time is yours.
Izin dokter, untuk koneksi Dr. Nazaruddin sepertinya ada kendala. Tadi sempat freeze untuk videonya, sedang kami perbaiki dokter.
Oh, terima kasih. Sorry. Okay. Kira-kira berapa lama?
Ke pembicara ketiga aja, Mas.
Ketiga. Oke.
Ya,
Oke. Ini masih ada background sound di belakang. Ini dari mana ya? Oke. Sudah bisa, Dr. Nazar? Oke. For the next speaker, Dr. Jian. Can you hear me, Dr. Jian?
Yes, I can.
Okay.
You want me to go first? Sure.
Okay. Sorry, because I think it's trouble with Dr. Nazaruddin.
Sure. No problem. I can go first. Perhaps makes more sense to after Sudadi's IRAS.
Yes.
Okay.
Thank you. Next, your turn, Dr. Jian with the IRAS in Neurosurgery, and your time is 20 minutes.
Sure.
Please.
All right. Can go to my slides. Go to my slides. All right. So I will continue with from Dr. Sudadi, who has given you an overview of IRAS in neurosurgery, and I shall continue from there. And perhaps I'm giving a slide. My slides can load my slides.
Yeah.
Okay, right. All right. Okay, so I shall continue from where Dr. Sudadi has left off, and perhaps give you a slightly different perspective of this is my personal view on this subject. So next slide. Okay, so I'm from Tan Tock Seng Hospital. I think we have been on this journey for a fairly long time. This is from our website, so you can see it from our website that we started this program in 2016. And what has been shared by Dr. Sudadi, the aim of IRAS is to ensure that there is faster functional recovery, decrease surgical complications, decrease hospital length of stay, and decrease readmission rates. Next slide. Next slide. Next slide. So this is also from our website. Tan Tock Seng is one of the Center of Excellence from the IRAS Society because we started this earlier, and we kind of work very closely with the IRAS Society. Next slide. So we started this with colorectal surgery, which is the first discipline that adopted the IRAS workflow and work processes very closely, and slowly we've expanded it to other sub specialties. So pancreas and liver hepatobiliary joined in 2018, upper GI, which is the bariatric surgery, as well as urology started in 2018, and then 2019 breast, head and neck, as well as the orthopedic total knee replacement, and in 2020 thoracic surgery came on board. You notice that there is no neurosurgery here, but anyway, next the next yeah. So obviously it makes for very good headlines, and there is some very promising and good results from our experience. So next slide. Next slide. So I shall back. I shall for the rest of my 15 minutes, go through very briefly. I think Dr. Sudadi has very eloquently shared with you what those principles are. I will just go through very briefly what those principles are, and what about it in neurosurgery, and finally a very brief anesthesia technique, which again Dr. Sudadi has given some snippets into what I'm going to say. Okay, next slide. So I think the key thing about IRAS is that it's a whole process. It is not just about the surgeon or just about the anesthesia. It encompasses the whole peri-operative journey, starting from pre-hospitalization to during hospitalization. And it doesn't stop there, but goes on to post-hospitalization. Next slide. All right, so just it's the same thing, but just let me drill down a little bit. You know, when all these things starts at the outpatient clinic, in the surgical clinic, and then it goes on to the anesthesia clinic. In our system, we have a pre-operative clinic, and that's where we do a fair bit of the counseling, preparation, education, and dietitian review, and even sometimes in one of the other programs that we have, the geriatrician review, before we go on to the operating room where there is carbohydrate loading. We allow them to take the carbohydrate drink before the surgery, and I'll come to the anesthesia technique bit, and so on and so forth. In the recovery, in the inpatient ward, they are seen by the physiotherapists very quickly, and so that they can be mobilized very quickly in order to achieve what we want to achieve. Okay, next slide. So these are all the elements, all right? The elements, there are many, many elements, and ERA society does all these various surgical procedure-specific elements. So they will define through, looking through the literature and best practices, and assemble a whole list of interventions that you need to do in order to achieve the kind of outcome that you hope to achieve. All right, and there are very, very granular details of how you get there, and also a very robust system of collecting this data to see how compliant you are with these elements. Because the key to all these ERA practices is that if you do an individual component of it, you are less likely to see any positive results. But if you do as many or as complete as you of all the elements that there is in there, then you will see the kind of results that you are hoping for. So the next slide. As you can imagine, since it spans across the whole perioperative journey for the patient, it is a very, very, in some ways, very labor-intensive endeavor, because it involves many, many disciplines. And involving many, many disciplines, involving many, many people, as you all can imagine, involves a lot of working closely. So I would like to put the word transdisciplinary. I think in our colorectal team, there is this common understanding and passion for this ERAs, and therefore when I say transdisciplinary, it means that it is no longer, okay, I am doing my surgical work, I do my surgical work well, and I pass it to the next person who is the anesthesia, and as an anesthetist, I do my anesthesia well, and I pass on to the next person. So it is more than that. It transcends that, because in order for this whole journey to be seamless, the surgeon will also need to take some responsibility for the anesthesia, meaning that they will then, for example, have a conversation with us, have a discussion with us of what are the aims of these patients are, and how we can then, as an anesthetist, tailor to their needs. And similarly for us, we also play a part in saying that, okay, I've done this in the anesthesia, I put in an epidural in this anesthesia, but I think this patient should not be complete rest in bed after the surgery. We should, allow the local anesthetic to wear out a little bit, and if the patient is strong, start mobilizing either bedside or more. So it moves much more than just saying that, okay, I do my part well, next somebody does their part. It has to come together as a very, very strong team for the ERAs to succeed. Next slide. And the whole, next slide. And the whole purpose is to hasten the trajectory. So this is a typical trajectory of what the patient undergoes. Patient has a baseline. The surgery is a massive insult to the physiology of the patient. Therefore, there is a drop in the functional ability of the patient, and all patients will recover. But instead of allowing the patient to recover in a slow, traditional way, next slide, what we are hoping to achieve is to accelerate it. If you can see the red line there, instead of allowing traditional trajectory of recovery, you want it to be faster at a steeper slope. And the underlying principle, as Dr. Sudadi has shared with you, is number one, decrease the stress of surgery. So in a colorectal setting, instead of the traditional open surgery, which is obviously a very massive surgery, if you can convert it to laparoscopic surgery, that is much less invasive, minimally invasive. The stress response is less. When there is less stress response, there is less insulin resistance. And that has been shown quite convincingly that that is related to recovery. In other words, if there is huge loads of insulin resistance from the stress of surgery, the wound healing is poorer, it takes a longer time, and so on and so forth. And it's also the basis of why carbohydrate loading, because if we fast ourselves for a very long time, the body will go into a state of fasting, and then it will be resistant to insulin, obviously, because we need to maintain sugar. And that in itself, and plus the surgical stress, will then lead to this prolonged recovery. All right, so those are the basis for why we want a minimally invasive surgery, carbohydrate loading, and similarly for the anesthesia part, we want to control pain so as again to mitigate some of the stresses of surgery. Now, fluid one is part of the ERAS elements in colorectal surgery. They found that over transfusion, that means giving too much fluids, causes edema in the gut. And that can affect the healing of the anastomosis. Therefore, there is a need to give just nice amount of fluids. All right, so that's a pre and intra. Post-op, the strong belief is that the earlier we mobilize the patient, the earlier we resume nutrition. Because you know that after surgery is a catabolic phase, there's a lot of muscle loss, protein and muscle loss, and therefore if we can get nutrition in early, that will again help the recovery faster. And similarly with mobilization, there is activation of the healing process. All right. The last point is prehabilitation. I mean, there is again increasing belief that instead of allowing the patient to dip and then recover, why not we elevate where the patient can be? So actually, in one of our programs, the liver program for elderly patients, liver and the colorectal program in elderly patients, we actually select some patients who are frail and elderly, and we send them through a period of prehabilitation, a bit of a physio exercising, and we've shown very small numbers that this is again effective in getting good results. Next slide. What about neurosurgery? Is there evidence for neurosurgery? Okay, so I was looking through the literature and in fact spine. In fact, we are also starting spine. We haven't officially jumped onto the bandwagon, but the individual surgeons are adopting this. So spine, there is fair amount of evidence. If you look at the slide, I know it's hard to read, but again, whole perioperative journey, again, change of trajectory. And if you look carefully, I'm struggling to read as well, but there will be slight modification. Again, same principles as the previous one. Perhaps the next slide will show a little bit better. Next slide. So this is a very recent spine journal, ERAS guidelines. So every time ERAS, once they have collected all their information, they will put up a proposal, and these are again listing out all the elements in the pre, intra, and post-op period, and how you can manage them in order to adopt this. So very briefly, again, what they emphasize, I'm looking right at the intra now because this is more anesthesia talk. Standardized anesthesia protocol, local anesthesia in terms of pain, focus on fluids, antibiotic prophylaxis, as well as focus on surgical technique, as well as the facilitation of early mobilization. Next slide. Okay, I know the audience is a little bit more interested in craniotomy. What about craniotomy? All right, next slide. The reality is, next slide. The reality is I don't find a lot of evidence. All right, this is a group by China, did quite a fair bit of work on this. They found that, next slide, they found that using their, they did not publish their protocol, but using a ERAS protocol, they found that, first of all, there's a better pain control. And number two, the length of stay is shortened. Next slide. Yeah, same thing. Next slide. And the same group, next slide, the same group also found that, I mean, the previous slide, but it's okay, also showed better patient satisfaction. Next slide. So I was wondering, what sort of protocol? Next slide. What sort of protocol do people use? Because personally, I think we are a little bit haphazard. We don't have a system at this point in time. And I examined this, and if you maybe spend a little bit of time looking at this, the focus of pre-op is again education, carbohydrate loading, and in this group, this is a group from India, gave a non-opioid analgesic, and then intraoperatively they give scalp block instead of local anesthesia infiltration. They ensure normothermia, and then fluid. They use goal-directed fluid therapy. They put a NG tube for all ERAS patients, a little bit different from what colorectal talks about, but anyway, that's what they do. Minimally invasive surgery, they again don't put surgical drains, and post-op they give Paracet and that non-opioid analgesic, and then rescue with fentanyl, and then mobilize no catheter or remove catheter as soon as possible, urinary catheter, and then restart diet and DVT prophylaxis. Right, next slide. So you have an idea. And what they show in that paper is again better pain control and no difference in outcome, neurological outcome. Next slide. All right, next slide. Next slide. All right. So it comes to the point of the anesthesia again. For craniotomy, I shall go through with you some evidence of the anesthesia technique in terms of, it's about anesthesia recipe here. So whether you want to do a wake technique or a GA, or you want to give a TIVA or a volatile, and what sort of analgesia strategy, and finally, what's the PONV strategy. All right, so let's go to the next one. So are awake techniques better? So some years back, the group in Toronto did a lot of day surgery, a lot of awake craniotomy, not necessarily in the eloquent cortex anywhere, and this is not that group, but essentially what they have shown is that awake craniotomy can be done for various tumors, and more and more people show that awake craniotomy leads to shorter hospital stay, can discharge earlier, and so on. All right, but next slide. This is a Toronto group, Maninan and Venkat, and with Mark Bernstein as the surgeon, and they yes, they do a lot of awake crani, and a lot of these patients are able to go home same day discharge. And next thing. Yeah, but they also found that actually whether it's awake or it's GA, as long as you select your patient well, you are able to achieve the endpoint, which is sending the patient home on the very same day. Next slide. And are awake techniques better, whether it's awake or general anesthesia? There is no difference in terms of the tumor recurrence or neurological outcome. All right, next slide. All right, so in terms of awake and so in other words, okay, so that's awake and GA. What about the GA techniques as well? Is there any difference between TVAR and volatile? The short answer is there isn't. Perhaps the next slide. I mean the next. All right, so if you look at this meta-analysis, comparing SIVO versus propofol as well as SIVO versus isoflurane, in terms of recovery, remember we are talking about ERAS. I want the patient to recover very, very fast. And if you look at between using propofol and sevoflurane, there is no difference. No difference. If you can argue the triangle, the diamond seems to may even favor SIVO slightly. But of course, if you use isoflurane, then that is in terms of recovery profile, it is a little bit less compared to propofol. Next slide. All right, so this is recovery. And then what about TIVA versus volatile again in terms of the other effects on the brain? Because in ERAS concept, you want the patient to wake up nicely and get going. Next slide. All right, so the conclusion is there is no strong evidence, even though perhaps TIVA is slightly better in terms of patients, elderly patients with cognitive outcome, So perhaps. All right. Next slide. Next slide. Okay. Same thing. Whether it's TIVA or volatile, at this point in time, at least. Of course, there are some criticism about all these studies and all that, but anyway, at this point in time, it doesn't seem to have an impact on the survival of patients with brain tumor. So next slide. So in summary, this is my opinion on anesthesia technique. I think there are advantages of awake if it is appropriate versus GA. In terms again, back to what I'm saying, is all about this ERAS concept. Evidence is not strong. But not everybody can undergo an awake craniotomy. I don't think it really depends on the tumor size, location, as well as the surgical consideration. They are very important. Not everything is all about the anesthesia. The surgical considerations are just as important. In terms of the technique, I find very little evidence favoring either. It is perhaps more important how you do it than what you use to achieve your goals. Next slide. So the other aspect of ERAS is analgesia, and there is obviously quite a fair bit of interest. I'm just going to go through this quite quickly because I know that Dr. Chong is also talking about scalp block, but I'm just sharing this Cochrane review, quite recent Cochrane review, looking at the analgesic modalities in craniotomy. Next slide. Next slide. All right, so NSAIDs. NSAIDs are, in summary, effective. However, of course, for those who use intravenous non-selective NSAIDs, then there is always a risk of bleeding, and therefore I don't think that is appropriate in neurosurgery, in craniotomy. However, for those who use selective ones like COX-2 inhibitors, not even in diagnosing, not every surgeon is comfortable using it. But there are increasingly more surgeons who are amenable to using it, and if you manage to use it, then the effect on analgesia is positive. Next slide. Next, medetomidine as an adjunct to GA. There is small evidence, weak evidence, but at this point in time, in this study at least, there is no difference between using dexmedetomidine versus control in terms of better analgesia. Next slide. Next slide. LA, the top one is the comparing scalp infiltration versus control. The bottom one is scalp block. So scalp block is a little bit more effective than LA. LA, of course, is a lot less technically demanding. You just give a local infiltration. Scalp block, you will need to perform the scalp block. I'll leave that for Dr. Chong to discuss a little bit more. So next slide. So in summary, for pain control, opioids, there is still a role for it. But the key in ERAS principle is to minimize opioid as much as possible. And there is increasing recognition of multimodal, be it scalp block, in other words, local anesthesia, or NSAIDs if you can. The others are a Paracet we give routinely because we find that it is quite safe to give, but it is effective, but not strongly so. So it is usually adjunct, not as a sole analgesic. IV lignocaine and gabapentinoids and the others like ketamine and all that, Dr. Sudadi has discussed. The evidence is not strong at this point in time, at least. Next.
Next slide.
Sorry?
The time is up.
Okay. Maybe just give me 1 minute to conclude. Next slide. Next slide. Okay. So in conclusion, my view is that unlike abdominal or thoracic surgery, the stress of craniotomy is definitely different. So how much more insulin reduction we can achieve using ERAS protocol, I'm not so sure. Is there a role for GDFT? I'm not so sure as well, because in general, a craniotomy is not a surgery that loses a lot of fluid. But to do this better, I think the focus on anesthesia techniques and focus on pain control, definitely there is a role for that. Post-op recovery, the aim of our anesthesia is always to ensure a very nice recovery, of course, with paying attention to PONV, nutrition and mobilization. One more slide, next one. And not to get me wrong, I do believe that relook at the traditional process is important. I believe that from all these studies, you can see that if you relook at what you have been doing and using what you know from the literature and what we have shared along this way, and to change the whole process will lead to an outcome. Whether you call it ERAS or not, it does not matter. Next slide. Next slide, last one, promise you, last one. So I encourage that because we want to achieve that trajectory. That's it. Next slide. That's my thank you slide. Thank you.
Thank you, Dr. C, for the presentation. Hopefully, it can be useful information for physiologists and participants of this seminar to perform clinical practice. Pembicara selanjutnya, Dr. Nazarudin Umar. Apakah sudah bisa ya?
Ya, kira siap.
Terima kasih. Oke, untuk mempersingkat waktu, monggo waktunya persilakan Dr. Nazarudin Umar, tepat jam 11.20, waktu 20 menit, kami persilakan Dr. Nazarudin Umar. Monggo.
Baik. Ya, siap. Oke. Ya, mulai. Baik. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam.
Oke, gangguan lagi nih. Oke ya. Baik, terima kasih. Assalamualaikum warahmatullahi wabarakatuh. Baik, kali ini saya ditugaskan oleh panitia membawakan suatu judul Management of Intractable Intracranial Hypertension. Sebelumnya saya ucapkan terima kasih pada moderator, sejawat saya, Dr. Rudi dan Semarang. Baik, slide. Jadi masalah tekanan intractable intracranial hypertension ini adalah suatu tekanan intrakranial yang sangat tinggi, saya kira lebih dari 25 mm Hg, bertahan bisa sampai 30 menit. Atau 30 tekanan 30 mg sampai 15 menit dan atau 40 mg dalam 1 menit. Nah, ini tekanan intrakranial sekian ini kalau dilihat nanti hubungan tekanan intrakranial dengan volume itu jelas otaknya udah bisa keluar. Kemudian kalau misalnya udah bertahan pada terapi yang 25 intractable tadi bisa bertahan jadi refractory hanya sampai lebih dari 20 mg selama 15 menit itu dengan terapi yang maksimal. Jadi dikatakan refractory intracranial hypertension. Ada juga di buku-buku nyatakan bahwa itu sama aja. Artinya tekanan intrakranial yang membandel. Ini banyak penyebabnya untuk terjadi tekanan intracranial hypertension ini, banyak penyebabnya tentunya masalah-masalah intracerebral, baik oleh karena tumor, atau karena impak, atau adanya tekanan daripada arteriovenous, misalnya pada keadaan ares sehingga terjadi udem otak yang sangat besar. Kemudian pasien ini mempunyai risikonya 15% dari severe traumatic brain injury, dan ini tentunya cukup tinggi dan cukup membahayakan. Nah, intractable intracranial hypertension ini merupakan high mortality, itu sudah jelas ya, sudah jelas high mortality. Ini menyebabkan oleh karena tekanan terlalu tinggi ini bisa menyebabkan brain ischemic dan herniasi yang menyebabkan juga kematian. Tentunya oleh karena tidak bisa dilakukan dengan tindakan sistem neuroanesthesia yang biasa. Dan problem yang mendasari pada tekanan intracranial hypertension ini, yang intractable ini, yang mendasari ada pada primary intracranial, masalah-masalah terjadi di intracranial maupun oleh karena extracranial. Jadi bukan karena intracranial saja yang menyebabkan tekanan intracranial tinggi. Jadi faktor-faktor intracranial juga bisa menyebabkan terjadinya tekanan tinggi. Nah, ini menyebabkan tekanan intrakranial tinggi pada intrakranial, misalnya tumor ya, brain tumor, ada trauma, misalnya epiduralimatum, pseudoralimatum, atau cerebral contusio. Kemudian traumatik bisa juga intracerebral hemorrhagic, bisa stroke, bisa hidrocephalus, ataupun oleh karena yang lainnya yang disebabkan di intrakranial. Namun, pada ekstrakranial itu misalnya pada airway obstruction, akibat hipoksia, menyebabkan hiperkardi, semuanya yang ekstrakranial akan memperjelek tekanan intrakranialnya. Jadi ada yang intrakranial, ada yang ekstrakranial. Masalah postur juga, hiperplexia, kejang, itu semua di ekstrakranial menyebabkan peninggian daripada tekanan intrakranial sendiri. Kemudian oleh obat-obatan juga. Berikutnya, slide. Nah, postoperatif juga bisa terjadi selama operasi baik-baik saja, tapi pasca bedah bisa menyebabkan otaknya bisa nggak tutup. Ya, oleh karena tentunya oleh karena hematom yang tindakan dari sendiri, kemudian menyebabkan edema, atau oleh karena adanya cerebral blood flow yang terjadi peningkatannya, misalnya pada vasodilatasi cerebral. Ya. Itu misalnya tiba-tiba terjadi masalah intrakranial tinggi karena masalah ulah kita. Karena gangguan 1900 split bisa juga. Lanjut. Nah, masalah karena intrakranial ini ada kaitannya dengan time is neuron ya, time is important. Jadi kalau pada keadaan primary injury, trauma yang pertama itu akan menyebabkan dilanjutkan nanti ke masalah waktu, baik dari mulai second sampai menit per hari, itu menyebabkan secondary injury yang bisa bertambah berat kalau tidak diatasi secepatnya. Primary injury ini sendiri tidak bisa kita atasi, tidak bisa diatasi. Kalau yang target itu adalah mengatasi tentang secondary injury ini. Inilah yang menyebabkan secondary injury ini yang bisa menyebabkan peningkatan tekanan intrakranial yang tidak teratasi. Baik. Ini menggambarkan suatu tabel ataupun suatu bahwa primary injury atau injury kemudian dilanjutkan dengan secondary injury. Direct injury itu misalnya oleh karena ada trauma langsung pada jaringan, pembuluh darah, dan akibatnya akan perubahan terjadi pada organ-organ yang lainnya. Jadi pada functional injury itu primary injury, traumanya tetap di situ. Tapi masalahnya, lanjutan daripada primary injury tadi akan menyebabkan rupturnya blood-brain barrier, menyebabkan vasogenik ödem, lanjutnya bisa tekanan intrakranial tinggi. Kemudian oleh kontusio, kemudian bisa juga menyebabkan iskemik. Iskemik ini nanti akan menyebabkan pasien glutamat, silesikopain, kalsium intraflow, kemudian menyebabkan neurotoxicity sampai necrosis dan apoteosis, yang akhirnya juga akibat secondary injury ini menyebabkan ICP yang sangat meninggi, yang menyebabkan intractable intracranial pressure kalau tidak diatasi dengan segera. Nah, ini kalau kita untuk masalah pengobatan pasien intracranial ini harus early intervention segera. Kalau kita sudah menampak ada gejala-gejala peningkatan tekanan intrakranial, kita harus segera mengatasinya dengan teknik-teknik anestesinya. Baik. Slide sebelumnya. Nah, ini karena kaitannya judul ilmiah kita hari ini adalah kaitannya dengan hubungan dengan simposium dengan berjudul ERAS pada Neuroanesthesia. Ini saya akan mencoba juga mengenalkan bahwa hubungan ERAS ini dengan kejadian tekanan intrakranial intractable. Ya, bisakah ERAS ini kita masukkan untuk menangani kasus-kasus intractable ini? Karena tadi sudah banyak membicarakan bagaimana ERAS itu pentingnya ERAS. Tentunya tidak sama pada pasien-pasien yang emergensi. Kalau tadi Dr. Dadi, mungkin Profesor tadi juga bisa menyatakan bahwa ada kasus-kasus yang elektif tentunya. Jadi sedangkan kasus pada intractable intrakranial ini sudah termasuk emergensi dan pasiennya umumnya kalau di intractable ini pasiennya sudah di ICU langsung dan tidak sadar dan pakai ventilator. Nah, bisakah ERAS yang kita lakukan seperti itu? Mungkin agak berbeda ya, agak berbeda. Jadi ERAS ini merupakan multimodal dan multidisiplin pada perioperatif management approach, akan menurunkan stress respon dan mengurangi komplikasi dan meningkatkan peningkatan hasil daripada perbaikan daripada pasiennya dan mengurangi hospital stay. Nah, di sini multimodal pada intrakranial yang Membandel ini multimodal ini sangat penting ya, misalnya pada pemakaian obat, alat, dan monitoring yang canggih tentunya tidak sama dengan yang diminimalkan semua tadi. Kemudian multidisiplin. Multidisiplin ini tentang masalah ya dokter anestesi sendiri, kemudian dokter bedahnya tentunya katanya spesialisnya. Makanya di bedah juga ada dikatakan bahwa eras in neurosurgery, jadi bukan eras neuroanesthesia aja, eras and neurosurgery. Nah, ini kemudian ini dilakukan juga pada preoperatif, intraoperatif, dan postoperatif manajemen, tentunya dari mula. Tapi pada kasus ini tentunya kalau preoperatifnya tentunya masalah pada keluarga karena pasiennya tidak sadar, ya, harusnya. Kemudian terus ini juga tadi sudah sampaikan banyak sejawat sebelumnya ya bahwa ada tindakan preoperatif, postoperatif, dan intraoperatif. Kita lihat dalam 3 ini di mana kita bisa masukkan erasnya pada tekanan intrakranial yang bandel ini, mana yang bisa slide. Nah, pada eras intraotomy surgery yang biasa tentunya saya ceritakan sedikit yang tentang yang tidak emergency ya, tentunya seperti tadi diterangkan ini slide seperti dokter tadi sudah kita juga tentunya yang perlu ditekankan proaktif pada pasien kasus intrakranial ini tentunya pendekanan pada keluarganya bahwa tindakan-tindakan yang kita lakukan ini sangat risiko dengan high risk yang mungkin saja bisa meninggal di meja operasi, istilah kita di Indonesia. Jadi preoperatif ini sangat berpenting pada keluarganya, konselingnya masalah risiko operasi dan tidak operasi, karena di situ yang kita perlu tekankan, tidak sama dengan yang preoperatif yang lain. Nah, kalau intraoperatifnya tentunya profilaksis antibiotiknya perlu, kemudian minimize scalp saving ini paling penting untuk mencegah infeksi, kemudian profilaksis antibiotik, cuman sangat penting kemudian scalp block. Ini juga scalp block paling penting, erasnya di sini sangat pentingnya pada intercable intrakranial ini. Apabila terjadi dilakukan dekompresi, craniotomy, hingga perlu blok infiltrasi yang cukup baik, sehingga nanti mengurangi gejala-gejala stress respon daripada pembedahan. Kemudian pemberian obat-obat analgetik juga kita harus perhitungkan apakah kita berikan opioid atau kita kurangi. Tentang pemberian scalp block tadi dijelaskan bahwa ini akan membantu terhadap bedahnya, ya, terhadap nyerinya. Jadi scalp block sisi masalah pada pasien-pasien yang dilakukan ini sangat membutuhkan, sangat diperlukan sebenarnya eras ini, tapi tidak semua seperti yang elektif. Berikut. Pada intraoperatif juga ini diperlukan minimal invasive neurosurgery. Jadi penting dilakukan manipulasinya tentunya harus dibatasi, ataupun teknik-teknik operasi sekarang banyak memakai alat-alat sehingga diharapkan bisa memakai alat-alat seperti itu. Kemudian nilai hindari hipotermi, kemudian terjadi invasive cardiac output, monitoring, kemudian masalah pas urinary drainase ya, setelah selesai nanti perlu diproses seperti terangkan sebelumnya tadi. Nah, pos operatif ini yang paling penting saya kira erasnya pada ini, karena ahli nutrisi ini sangat penting pada pasien-pasien yang ini, karena pasien-pasien dengan ICS-nya jelek, kemudian nutrisinya tentunya harus ditingkatkan sebaik. Dan kalau misalnya mobilisasi ini tentunya nanti kalau misalnya terjadi ada perbaikan akan dilakukan mobilisasi dan dilakukan mobilisasi dan massage ya. Baik. Berikut. Nah, jadi goals terapi daripada tekanan intrakranial yang tinggi ini tentunya ada goalsnya ya. Kita harus mempertahankan intrakranial pressure berkurangnya 20-25 menit terakhir, kita bisa mempertahankan 20. Kemudian maintenance cerebral perfusion pressure-nya lebih dari 60. Kemudian maintenance bisa MAP-nya kita pertahankan sekitar 40-60. Kita hindari faktor-faktor menjelek persepsitas daripada intrakranial pressure. Faktor-faktor misalnya hipoksia, hiperkarbi, hiponatremi, semua itu harus kita hindarkan faktor-faktor terjadinya untuk peningkatan intrakranial yang ekstrakranial. Nah di sini saya sengaja mengambil urutan tingkatan pemakaian alat-alat atau obat anestesi, terutama pada neurosurgery, tapi pada ini termasuk pada umumnya ini tier ini ada sampai bermacam-macam menurut buku, ada yang dimulai dengan tier 0, ada yang tier 1 ya, tier 1. Tapi pada kasus ini saya ngambil tier 0 dan tier 3 sampai 3 ya, karena nantinya masuknya intrakranial yang membandel ini pada tier 3. Jadi kalau pada tier 0 ini biasa seperti mengatakan in of bed 30 derajat, 20 derajat, sehingga menyebabkan aliran darahnya akan menurun. Berikan adekuat, ya, korek hiponatremi, dan pertahankan CPP-nya 60 sampai 70 mg. Dan normokarbi tentunya 35 sampai 45, dan good oxygenation. Ini dasar-dasar pada tier 0. Berikut. Nah, tier 1 ini tetap skor di RW, cerebral perfusion pertahankan, memberikan sedasi, kemudian berikan kita dan mulai bisa memberikan manitol. Kemudian ataupun hipersalin ya, atau salin, kemudian memasang cerebral spinal fluid, kemudian EEG monitor. Ya. Nah, di sini yang berperan pada tekanan pemakaian pada intracranial intracranial pressure, CRTU ini udah mulai kita memakai. Karena kan di sini perlu kita pertimbangkan untuk bisa pertimbangkan kapan kita menggunakan dekompresi kraniotomi. Apabila sudah tier 2 ini udah mulai tidak bisa kita pakai, misalnya manitol, hipertonik salin, kemudian tindakan-tindakan yang lain tidak menolong, kita nanti akan bisa masuk ke tier 3, karena tindakan-tindakan yang di urutan ini untuk tekanan intracranial bandel ini tidak masuk lagi. Namun urutan ini harus kita jaga, kita jalankan. Baik, berikut. Nah, tier 3 ini yang bisa membantu pada tekanan intractable, tekanan intracranial yang tinggi tadi, yaitu pemberian pentobarbital, ya, diinfuskan atau disebut dengan koma barbiturat koma, ya, tiopental. Kemudian tindakan yang lainnya pada tier 3 ini, indus hipotermi, ini pertahankan 35 sampai 36 saja, nggak boleh terlalu rendah. Kemudian hiperventilasi, ini harus hati-hati, kita jangan kebablasan sampai PCU2-nya terlalu rendah, ya. Kemudian harus dimonitor dengan ketat. Kemudian peningkatan MAP bisa kita pakai untuk mencegah CPB, jangan MAP-nya terlalu rendah. Nah, senjata yang terakhir ialah secondary decompressive craniotomy. Nah, di tier 3 inilah penanganan pada penekanan intrakranial yang membandel tadi di tier 3 ini. Jadi kalau yang lainnya, tindakan-tindakan pada neuroanesthesia atau neuro itu bisa dipakai, sedangkan pada kasus ini akan tambahan barbiturat koma dan sendiri decompressive craniotomy. Right. Nah, ini barbiturat koma yang tadi beda dengan yang lain pada tier 3 tadi, ini kita bisa gunakan start loading dose-nya 10 mg per kilogram berat badan intravenous selama 1 jam, kemudian nanti dilanjutkan 5 mg per kilogram berat badan continuous, kemudian diulang setiap 3 jam. Nah, kemudian bisa diterasi infus 1-5 mg per kilogram berat per jam, maintenance-nya untuk mencegah burst suppression 2-5 burst per menit. Nah, tentunya pemakaian kita barbiturat koma ini tentunya kita memerlukan alat-alat yang perlu monitoring, jangan sampai terjadi hemodinamiknya gangguan, hemodinamik berberat atau oksigenasi terganggu, sehingga kita perlu alat-alat yang untuk monitoring yang tadi multimodal tadi, sehingga bisa dipertahankan hemodinamiknya. Karena barbiturat ini jelas menyebabkan hipotensi, ya, menyebabkan hipotensi, tetapi memperbaiki cerebral blood flow. Nah, ini contoh dekompresi kraniotomi. Itu jadi pada subdural hematomi yang berat, kita lihat bahwa nilai shift-nya cukup jauh, ya. Jika dijadikan
Dokter
ya
2 menit.
Oh ya, makasih. Baik, dekompresi kraniotomi ini kita lakukan apabila sudah yang urutan tadi tidak bisa dilakukan. Ini kita lakukan dekompresi kraniotomi. Contohnya yang pada saat lingkaran ini sudah dilakukan dekompresi kraniotomi, nilai shift-nya kembali semula. Jadi ini contoh dekompresi kraniotomi yang temporal. Berikut. Nah, ini kan kalau kita bisa melakukan bifrontal dekompresi kraniotomi, ini contohnya, jadi depannya itu kiri-kiri bifrontal dibuka sehingga menyebabkan tekanan intrakranialnya bisa berkurang. Ini contohnya pada slide-nya CT, pada scanningnya itu kita lihat udimnya luar biasa. Kita pakai bifrontal dekompresi kraniotomi. Berikut. Nah, ini alat-alat yang multimodal yang saya katakan tadi yang perlu dipakai. Tentunya kalau kita melakukan dekompresi kraniotomi kalau pasiennya mau selamat. Tentunya kita memerlukan ICP monitoring, reduce oxygen tension, cerebral microdialysis, jugular venous oximetry. Karena makanya erasnya di sini perlu tekankan membutuhkan perlu adanya alat ini dan teknik anestesi tadi dan teknik operasinya. Gitu. Ini non-invasive cerebral monitoring juga perlu alat-alat multimodal. Gitu. Nah sebenarnya goal neuroanestesi itu ya pada pasien yang lain juga, sebenarnya deep anestesi dengan adequate master relaksan dan mencegah intubasi blunting supaya jangan terjadi gejolak hemodinamik, kemudian pemakaian masker anatomi itu jaga jangan sampai terjadi nyeri yang hebat. Kemudian paling penting jangan meningkatkan ICP dan cerebral blood flow dan blood pressure dan tidak menurunkan cerebral perfusion pressure, cerebral blood flow dan blood pressure, no hipoksia dan hiperkarbi. Ini merupakan goals dari neuroanestesi, target kita untuk menurunkan itu. Kemudian perioperatif monitoring, tentunya semua tadi ERAS tadi di sini perlu kita gunakan sehingga ERAS-nya jelas tadi di mana pada pentingnya pada tekanan intrakranial yang tinggi, gitu ya. Ya, ini sekedar take home message pada yang kasus yang cerita yang saya bawakan ini adalah ini ERAS ini sangat direkomendasi untuk penanganan intracranial hypertension, mungkin harus dilakukan multimodal dan multidisiplin. Tentunya mendetailnya perlu dilakukan sebaik-baiknya pada penelitian nanti perlu penelitian lanjutan bagaimana ERAS ini tidak masuk sempurna pada intracranial cranial. Kemudian terapi pada ini yang spesifiknya beda dengan teknik-teknik operasi pada tumor otak yang lain, hanya memakai normal barbiturat dan komplekstomi. Ini yang sering senjata terakhir merupakan walaupun pada tindakan operasi yang lain akan dipakai juga pada komplekstomi ini. Saya kira ini yang bisa saya sampaikan. Mudah-mudahan ada manfaatnya. Terima kasih. Maaf gangguan sinyal ya, sehingga saya baik. Terima kasih. Assalamualaikum warahmatullahi wabarakatuh.
Terima kasih Dr. Nazarudin atas presentasinya, dan berikutnya adalah presentasi terakhir. Based on the topic, I think it's very interesting topic and must try to perform scalp block anesthesia technique from the presentant. Dr. Chong Chintek. Dr. Chong.
Hello, good afternoon, everyone.
Okay, now you have 20 minutes for your presentation and the time is yours. Please.
Okay, Chairperson, I already sent my video recording to the Secretariat, so they will play my video.
So how can ERAS protocol help these patients? Today is ERAS, or Enhanced Recovery After Surgery, for Neurosurgery, was first mooted by Henry Kellett in the 1990s as a multimodal approach to improved postoperative physiology and rehabilitation. It consists of multiple components of care targeting the reduction of stress and the burden of disease, immune response and pain, and This is an overview of the entire process, ranging from the pre-hospital and immediate pre-operative phases entitled to the intraoperative and post-operative and then post-discharge phases. On surgery, I will pick a few important processes to elaborate. The burden of disease. As an overview, I will cover the current landscape of clinical trials of brain tumors, of surgical procedural innovation and improvement in anesthetic and surgery for brain tumors associated with enhanced post-operative incidence of complications. And finally, also ranging from stroke to myocardial anesthesia drugs to infection affect longer-term outcomes. More than 6% of patients require a that is probably what matters most. And these surgeries are also associated with greater risk of post-disease-free survival, cognitive decline.
Hello, Secretariat. There's a lot of people. Maybe the person that is hosting the video can mute themselves.
So how can ERAS protocol help just these a little patients? Bit on history. ERAS, definition or recovery surgery under awake craniotomy, was first mooted by Henry Kellett in the 1990s.
Panitia, mohon maaf, videonya hilang.
Baik, Dok, siap, Dok. Mohon maaf, Dok, ini sedang kami perbaiki. Mohon maaf, Dokter.
The topic of my presentation today is entitled Enhanced Recovery for Neurosurgery, with a primary focus on surgery for brain tumor resection. The burden of disease is actually not small. In the United States, the incidence of brain tumors is 12 per 100,000 person years, and surgery for brain tumor is associated with a significant postoperative incidence of complications, ranging from stroke to myocardial infarction to infection and mortality. More than 6% of patients require a reoperation, and these surgeries are also associated with greater risk of postoperative cognitive decline and decreased in functional status in the long term. So how can ERAS protocol help these patients? ERAS, or Enhanced Recovery After Surgery, was first mooted by Henry Kellett in the 1990s as a multimodal approach to improved postoperative physiology and rehabilitation. It consists of multiple components of care targeting the reduction of stress and the reduction of immune response and pain, and also the minimization of catabolism after surgery. Hopefully, these then translate to real-life patient-centric outcomes. This is an overview of the entire process, ranging from the pre-hospital and immediate pre-operative phases to the intraoperative and post-operative and then post-discharge phases. I will pick a few important processes to elaborate. As an overview, I will cover the current landscape of clinical trials, how surgical procedural innovation and improvement in anesthetic techniques play a big part in enhanced recovery after surgery, and finally also whether our anesthesia or anesthesia drugs use affect longer-term outcomes in terms of tumor recurrence. That is probably what matters most to patients, whether or not they can get improved disease-free survival. But it is probably not easy to prove the superiority of any one anesthetic technique over another in this aspect. Just a little bit on history. Trephination or burr-hole surgery under awake craniotomy started in the medieval times. It is the oldest surgery for which there is archaeological evidence. Also, although ERAS first took off in a big way for colorectal surgery, you could say that ERAS for neurosurgery started way long ago. Of course, there are also enhanced recovery protocols for spine surgery, but I will just concentrate on ERAS for oncologic craniotomies. I refer next to this review article on ERAS for oncologic craniotomies. Similar to the general ERAS framework I showed earlier, ERAS for craniotomies cover guidelines on best practices for preoperative counseling, preoperative cessation of smoking and alcohol, avoiding excessive prolonged preoperative fasting, the use of regional anesthesia such as scalp block, and the use of opioid minimization or opioid-free techniques, routine post-op prophylaxis with dexamethasone or 5-HT3 antagonists, and also routine cefazolin antibiotic prophylaxis. It is also important to avoid hyper and hypothermia, as well as to avoid unnecessary usage of lines and tubes. There is also a mention on minimally invasive surgical technique where feasible. This is a neurosurgical trial which shows the safety and efficacy of a neurosurgical enhanced recovery protocol after elective craniotomy. The neurosurgical ERAS protocol has shown to result in shorter median length of stay, milder postoperative pain, and a shortened duration of pain. The time earlier taken to receive fluids and solid food was also much reduced compared to conventional management. In this table, there's also a tendency towards secondary outcome reduction of infection, respiratory complication, and deep vein thrombosis, although the reduction of these secondary outcomes did not achieve statistical significance. So here, just to recap the components of ERAS for neurosurgery, and I will select a few to elaborate further. Firstly, improvement in surgical techniques are very important to enhance postoperative recovery. The development of more advanced neuroimaging technology has enabled minimally invasive and targeted craniotomy, which results in better outcome for patients. In my hospital, for example, the neurosurgeons have started to use brain path, which is a minimally invasive technique to remove intracranial hematoma. The conventional removal of intracranial hemorrhage, as shown on the topmost slides here, usually result in a lot of collateral or surrounding damage and edema. However, the brain path technique results in less surrounding damage, such that in almost all cases, the bone flap can actually be put back. These pictures show the path to least damage while evacuating the intracranial hematoma. Next, a mention on the anesthetic technique of awake craniotomy, whereby we uphold the principle of less is more. This is a picture of craniotomy done in the medieval ages, not much different from current modern awake craniotomy. Traditionally, awake craniotomy is performed to resect lesions near functionally important or eloquent areas of the brain, such as the motor cortex or speech area. By keeping the patient awake or consciously sedated, brain mapping is facilitated and tailored resection can be achieved to minimize postoperative neurologic deficits. Currently, some centers are using awake craniotomy on an extended or expanded indication, regardless of the location of tumor. There is even a call to make awake craniotomy more routine, as less is more. More can be achieved by lesser amounts of drugs given or using ultra-fast offset drugs and avoiding unnecessary lines such as invasive lines or urine catheter, since a general anesthesia is avoided. So just to recap the principles of awake craniotomy, usually minimal sedative drugs which depress wakefulness are used, thus allowing for intraoperative neurologic monitoring. This also then facilitates faster recovery after the surgery. A very limited craniotomy aided by neuronavigation results in much less surgical trespass, and we also often use ultra-fast offset drugs. This again enhances neurologic recovery. Again, in the process of awake craniotomy, we avoid unnecessary invasive lines and tubes. Next, a mention on opioid sparing or even opioid-free anesthesia for craniotomy. using less or absolutely no opioids is advantageous because miosis, postoperative nausea and vomiting, postoperative hyperalgesia, CNS and CVS and respiratory depression, post-op cognitive deficit, and more recently an association with tumor angiogenesis and recurrence of the tumor are of major concern with opioid use. The crucial anchors of opioid-free anesthesia are local anesthetics and a scalp block, dexmedetomidine infusion, and other analgesic adjuncts such as paracetamol or maybe even NSAIDs and ketamine in some centers. Hence, there is now a paradigm shift. Opioid analgesics should be used as rescue therapy rather than routine therapy. Many different protocols have been described to achieve opioid-free anesthesia with or without local regional blocks for various different types of surgery, including major cancer surgery. There is now a new paradigm in the analgesic pyramid. Opioid-free anesthesia represents a refreshing wind of change. In the old way, opioids form the foundation of our analgesia management. But in the new way, we reserve opioids mainly for severe pain or as rescue therapy. So in my hospital, some of us have started to use opioid-free anesthesia on a routine basis for supratentorial craniotomy for brain tumor resection. Next, how about fast-tracking discharge after neurosurgery? In some centers in North America, in carefully pre-selected patients, it has been shown that same-day discharge for supratentorial tumor resection is feasible, especially since a general anesthesia can be avoided, thus enhancing recovery. As mentioned earlier, in some centers in North America, they actually promote the use of an awake craniotomy technique, not just to avoid a general anesthesia, which then enhances and quickens recovery. It also helps to reduce resource utilization in that there is a lower need for ICU admission, a reduction in hospital length of stay, and generally a reduction in complications associated with a GA. Of course, this requires very careful pre-selection of the appropriate patients. Going back to the question of post-op disposition, do all patients require routine admission to the intensive care unit after elective craniotomy for brain tumor? In fact, it can be argued that if we were able to achieve immediate successful extubation after elective craniotomy, whereby a surgical duration is under 4 hours in a non-prone position, then the patient can be monitored safely in the PACU before being discharged to the Neurologic General Ward instead of the intensive care unit or intensive care high dependency. In fact, same-day discharge for craniotomy, also known as outpatient craniotomy, has been shown to still preserve patient satisfaction and also not result in an increase in complications, provided the patients are selected carefully. Same-day discharge is possible after many cranial procedures, for example, stereotactic biopsy, and then as mentioned, supratentorial brain tumor resection, or unruptured aneurysm clipping or coiling, or microvascular decompression for cranial nerve neuralgia. The crucial thing in making this successful is that an early post-op CT scan is performed 4 hours to pick up any early complications such as bleeding. If the patient then has uneventful PACU observation, a good CT scan is able to fulfill standard discharge criteria, then early discharge or even same-day discharge can be facilitated. It has been shown to not adversely affect patient clinical outcomes and patient satisfaction. Finally, a brief mention on whether the anesthesia drugs that we use affect longer-term outcomes such as tumor recurrence and survival. At least in the laboratory, morphine and other opioids have been shown to cause tumor regrowth and metastasis due to neoangiogenesis amongst other factors, which is why I talked about trying to achieve an opioid-sparing or opioid-free anesthesia technique earlier on. Earlier meta-analysis has also suggested that TIVA propofol, as opposed to an inhalational-based anesthesia, may be associated with better recurrence-free survival and overall survival. However, more recent RCTs do not demonstrate such a benefit when using TIVA. Hence, this area still requires much research into finding out whether or not a TIVA versus inhalational-based technique, which is more superior in providing better long-term outcomes, is still very much needed. In conclusion, I would just like to share some personal reflections. Firstly, some ERAS concepts are not applicable to craniotomy. Conversely, there are other unique techniques more relevant to craniotomy. For example, the use of scalp block, and also the use of the awake anesthesia technique, and also minimizing or shaving to reduce postoperative wound infection. Next, the effect of a bundle of care is often greater than the sum of parts contributed by each single intervention. And finally, for cancer surgery, I think long-term outcomes beyond the more immediate postoperative outcomes like early discharge, long-term outcomes like tumor-free survival are even more important. So thank you once again, and I'll be happy to take any questions, or you could email me at my hospital email if there should be any queries later on.
Oke. Skillnya sudah berakhir. Oke. Terima kasih, Dr. Chen. Thank you, Dr. Tong for your presentation. I think it's a
technique in neuroanesthesia. There are actually 6 sites to be blocked, and it can be remembered using the mnemonic SSAZOO or SAZO. In each nerve, you can give about 3 mL of mixture of local anesthetic marcaine with lignocaine onto each nerve. So for the first nerve, the first S, it is known as the supraorbital nerve. Just feel for the supraorbital notch, okay, through which will arise the supraorbital nerve. At this region, you can give about 3 mL of the local anesthetic. It will provide anesthetic coverage to a large portion of the frontal area. The next nerve is the supratrochlear nerve. This nerve can be blocked by giving lignocaine and marcaine local anesthetic at the bridge of the nose. The next nerve, or the third nerve, is known as the auriculotemporal nerve. What you should do is to feel for the pulsation of the superficial temporal artery at the tragus of the ear. Okay, avoiding hitting the arterial pulsation, you can infiltrate about 3 mL of the local anesthetic mixture. Next is the zygomatic temporal nerve. Okay, again, you can actually feel for the lateral border of the orbit. Okay, infiltrate again about 3 mL of the local anesthetic, and you will be able to block the zygomatico-temporal nerve. For posterior craniotomy, there are 2 nerves to be blocked. The first nerve is found at the greater occipital protuberance. Avoiding the posterior occipital artery, infiltrate about 3 mL of local anesthetic to the occipital nerve. And finally, the lesser occipital nerve, which is the nearby nerve to the greater occipital nerve, can be infiltrated by feeling for the bony prominence, the mastoid process. So this is a summary of the classical scalp block that can be given during craniotomy. If you are only doing a frontal craniotomy, then you only need to block the anterior nerves. Okay? If you are doing a posterior craniotomy, then you will have to block the posteriorly sighted nerves as well. So this is the scalp block revised technique again. Thank you.
Sudah. The video is over. Committee, Dr. Jian.
Hello.
Okay, thank you. Thank you, Dr. Jian, for the inconvenience. I think when I interrupt the presentation before, because I think your video is over, but I think your video is have 2 parts, I think. Okay. And I think the presentation is over for all the all the speaker, and we have only 15 minutes to make a discussion and question and answer. I think the committee can share the question. Mungkin dari panitia bisa men-share apa yang mau ditanyakan kepada para pembicara. Ini kita waktu masih ada 15 menit sampai jam 12. Ini dari Dr. Bambang Suryono kepada Dr. Sudadi. Bisa monggo langsung dijawab, Dr. Sudadi.
Terima kasih Dr. Rudi waktunya, dan untuk Dr. Bambang chat ya. Jadi berapa lama kembalinya fungsi status yang dapat dianggap untuk kasus tertentu. Jadi satu kasus mempunyai protokol yang berbeda dengan kasus yang lain. Jadi kalau disamaratakan bahwa kapan dianggap M.Kes, tentunya batasannya tidak jelas. Jadi sebetulnya kalau eras ini dianggap batasannya adalah outcome yang baik, tentu di preoperatif kita akan optimalisasi supaya hasilnya baik. Kemudian durante operasi kita meminimalisir stres yang ada, dan di post-op meminimalkan komplikasi yang terjadi. Jadi outcome yang diharapkan adalah paling tidak lebih cepat recovery dibandingkan dengan prosedur biasa yang dilakukan. Ini kalau dianggap sebagai eras tujuannya untuk outcome yang baik. Tetapi memang ada batasan-batasan yang menyampaikan bahwa eras itu kalau bisa keluar paling 2 atau 3 hari atau sampai paling lama 5 hari. Nah, tentu itu pun masing-masing kasus akan sangat berbeda. Jadi kalau menurut pandangan saya bahwa eras itu yang penting adalah outcome dengan optimalisasi dari preoperatif, durante, dan pasca operatif. Kemudian apakah ada kontraindikasinya? Kalau batasannya adalah waktu luaran dari rumah sakit, tentu pada pasien-pasien dengan GCS yang rendah, kalau keluar dari rumah sakit akan lebih lama. Nah, tetapi kalau batasannya adalah luaran yang baik, tentu tidak ada kontraindikasi. Demikian, dokter. Terima kasih.
Terima kasih, Sudadi, Ani, for Dr. Jian. Yeah, specific. Please, you can answer the question, Dr. Prof. From Dr. Diana Vitasari from Budiasi Hospital.
Oh, okay. Okay, I think it's the same question that was on the Q&A. I did type in some answer to that, but anyway, yes. The answer is not necessarily so, but of course, trying to understand that ERAS is a package. ERAS is not about one or two interventions that is done, for a particular surgery. So in other words, which is why, for example, we take again the example of the colorectal surgery. All colectomies, all anterior resections are all included in that protocol, in that ERAS protocol. So I can imagine that similarly for neurosurgery, if you were to translate the same sort of principle to neurosurgery, is you have to, number one, look at what is your perioperative cause for example, a meningioma, supratentorial meningioma, and how long does the patient stay in the hospital? How long does the patient stay in the ICU? And you look at it honestly and ask yourself, how can you then improve the whole perioperative journey? So to answer the first question, is there any specific criteria? I think the criteria is set by the team themselves. You look at what is the perioperative journey of your patient and that group of patients, that is, and you decide that perhaps there are ways of making this whole perioperative journey more value. I mean, of more value. In other words, you need to spend a shorter period of time. So in my answer earlier, I did say that it doesn't matter, because even in complex surgery, there is still a lot of room for improvement. Obviously, one could have very fantastic results. You go for the easy, low-hanging fruits. You go for the simple tumors. Like even if you look at the series in Toronto, they are small tumors. They are small tumors, and therefore their results are impressive. But that does not mean that a big tumor or a difficult tumor, you cannot do anything about it. But you can devise a protocol, a standardized protocol based on some of those principles that Dr. Sudadi, Dr. Chong, and myself and Dr. Nazaruddin has shared, and see how you can then shorten the whole perioperative journey. Yeah, but it is a whole team effort. In other words, it is not just about anesthesia. In fact, anesthesia plays a very small role because the whole journey is not just the surgery itself. It starts at the beginning, way before the patient even presents to us, and way a lot also in the rehab, in the immobilization that happens way after the anesthesia. I don't know whether I've answered the question completely.
Thank you, Dr. C. And the next question, oh yeah, Windu Baskoro, Dr. Windu Baskoro. Okay, and Dr. Sp.An, this is your question for Dr. Chong. Oh, yeah, this is your topic because your topic is too interesting for us. It's very relevant in the district area. So please, Dr. Chong, you can answer the question.
Sorry, Chairperson, which question? Do we need, what is the?
Dr. Otavia and Windu Baskoro. This is a question for you. How to just operate dose in intraoperative and postoperative setting using ERAS principle if we encounter severe scalp block in neurosurgical procedure?
Okay, okay, so for myself, whether to do a scalp block, I actually have to discuss with the surgeon. Not all surgeons like the anesthetist to give the scalp block. Then the other thing is in order to encounter less chance of not working scalp block, sometimes if the surgery is very long, you can repeat the scalp block at the end of the surgery. So how to adjust the opioid dose? You have to wait until you wake up the patient, and then you can ask the patient for his pain score, then you can give the dose judiciously. Yep. So what I have done in my practice is actually I try to do opioid minimal or even opioid free craniotomy. So usually that being the case, then if the patient is in pain after waking up, then I will give the opioid. Yeah.
And the second question from Windu Baskoro. How about the success rate for ERAS in posterior neurosurgery plastic scalp block? And do we need guiding dose to increase the success rate?
Oh, okay, so for the most part, I've been focused on supratentorial tumor resection. So posterior surgery, I think usually post-fossa surgery would be a bit more complicated near the brainstem, may not be suitable for ERAS, yeah, depending on the pathology. So most of the points that I've talked about is actually for supratentorial surgery. So for post-fossa surgery may not be so successful or may not be so applicable.
I think it's very interesting to answer. And the next question, oh, the last question from Dr. Jian there. Oh, for Professor Jian. What is a practical example of the application of ERAS in anesthesia? For example, operator surgery on intracranial hemorrhage.
I'm sorry, I just need to get back to this. It's not on the slide, right? Okay.
Yes.
Yeah. As I've said, as I've shared in my slides, we have not formally launched any ERAS for neurosurgery. So perhaps that's an admission that we haven't gotten ourselves sorted out as well. But as I've shared in my talk, I think it is not just about, ERAS. ERAS is just a term, right? Enhanced recovery. And it's a whole process, again, as I've said many times. It is not just about anesthesia. If you ask me, so for example, if you ask me, the Toronto's group that organize themselves to discharge patients on the same day for patients with small tumor, supratentorial, small tumor, done under awake technique mostly. That is in some ways an ERAS. Or at least, they want the patient to quickly get out of the hospital, quickly go home, minimal stay in the hospital. That is an ERAS protocol. Therefore, if you want practical advice, I suppose is to look at the cases that you've done. And obviously, the elective cases are generally the
easier thing to do because it is more predictable. The whole perioperative course is more predictable. They come in, they have time to, you have time to prepare them. You have time to consider nutrition, physiotherapy, and then you have time to prepare your anesthesia, standardize your anesthesia, go for opioid sparing, go for fast acting, go for good PONV prophylaxis, and then have a planned recovery phase. When do you take off the A-line? When do you take off the drains? And when do you start feeding? Are they good enough to feed? Is there any bowel involvement and all that stuff? So if you look at it all in all, if you ask me, the easier one would definitely be the small supratentorial tumors. You look at your results, what has it been? And then you try to write up a protocol that spans across the pre, intra, and post-op period and see if you can then improve it. And I can assure you, if you do that, there will be an improvement because it's very easy. Because I think we now do not look at all these things in great detail, and therefore there is plenty of room for improvement, if you ask me. As for complicated and emergency surgery, that has a lot of variability. You know, not all ICH are the same. Not all emergency head injury are the same. And in order to write a protocol for such group of patients, in my mind, it's not impossible, but requires a lot more effort and cooperation from different people. I mean, that's my simple answer to the another difficult question.
Difficult question for specialist person. Oke, akhirnya waktu sudah berakhir karena sudah menunjukkan jam 12 ya. The time is over, and thank you for all of the speaker, yeah, for your time and sharing your knowledge and experiences, and may God bless and protect you all. And terima kasih kepada semua pembicara atas waktu dan sharing informasi dan pengalamannya. Semoga Tuhan melindungi kita semua. Amin. Ya Rabbal Alamin. Untuk waktu selanjutnya kami kembalikan kepada MC. Monggo, karena udah lewat waktu, monggo saya kembalikan kepada MC. Silakan.
Thank you.
Thank you. Thank you.
Thank you, Dr. and all speaker for the presentation. We will take a photo for documentation, please. Please, Dr. Rudi Prihartono, Dr. Sudadi, Dr. Nazaruddin Umar, Professor C. Jian, and Dr. Chong Chin Tet for turning on the camera, please. Starting video. We will take some photo shoot. Cheers. Excuse me, Dr. Chong Chin Tet, can you turning on camera? We can take for the photo shoot. Okay. 1, 2, 3, cheers. Once again. 1, 2, 3, cheers. Okay. Thank you for all moderators and all speakers. And for the participant, the Symposium 1 with the topic Eras in Neuroanesthesia has finished, and we'll take time for the break for a lunch and praying time until 1 p.m. And for the next symposium, the Symposium 2 with the topics traumatic brain injury at 1 p.m. Jakarta time, and Symposium 3 with the topics brain tumor at 3 p.m. Please join again for the continuing webinar at 1 p.m. in the same link. Thank you for the participant from all audience. Assalamualaikum warahmatullahi wabarakatuh. God bless you all.
Itu di mute.
Ikutin sama Pak Luhut di sini.